Okay.
Hello, good evening. Today,
I will start by question number 1. The pressure within the balloon. Good evening.
Wait, Dr. Isra. Minute, please.
Sorry.
Okay, today we will start again to continue Fawzia Sheet 1 illustration. We will just repeat the few questions we started yesterday, as we started late, and then we will continue the sheet together. I need everyone, please, to read 5 questions and then to the other. I think we solved around 40 questions yesterday, and then we will continue the rest of the sheet. Okay, Dr. Isra, you can start.
Okay. Bismillahirrahmanirrahim. Question number 1. The pressure within the pleural space is negative with respect to atmospheric pressure, except for which of the following? At end expiration, at end inspiration, during a Valsalva maneuver, if the patient has a tracheostomy when taking a deep breath. My answer is C, during a Valsalva maneuver.
Okay, during Valsalva maneuver, and we said this is one of the maneuvers that the intrathoracic pressure always negative pressure to allow good venous return and for normal physiology of respiration and cardiac cycle. But in some conditions, like physiological condition, like during Valsalva maneuver, it is positive. The others are some pathological conditions like pneumothorax, hemothorax, hydrothorax, or pyonthorax. It is positive, and this is pathological conditions. Also, it is positive in ventilated patient on positive pressure ventilation, whatever continuous or interrupted. Okay. Next question, Dr. Isra.
Question number 2. A 30-year-old alcoholic man presents with acute severe upper abdominal pain and vomiting. He is admitted to the intensive therapy unit with a diagnosis of severe acute pancreatitis. 48 hours later, he developed peripheral paresthesia and carbopetal spasm. The most likely underlying metabolic abnormality: A. Hyperkalemia, B. Hypernatremia, C. Hypokalemia, D. Hypokalemia, E. Hyponatremia. Okay, my questions. My answer C. Hypokalemia. Hypocalcemia, I say.
Okay.
Hypocalcemia.
Hypocalcemia. Okay, as we said, hypocalcemia is a result of hypocalcemia is a result hypocalcemia is a result, but hypercalcemia is a cause. Okay.
Okay.
Clear? So
yes,
if
clear,
hypercalcemia, hyperparathyroidism, so this is a cause of acute pancreatitis or sometimes chronic pancreatitis in patients with hyperthyroidism for a long time. And hypocalcemia is a result, and it is one of Ranson's criteria. One of Ranson's criteria that we depend on following the patient and how to evaluate the patient in the first 48 hours after leaving or after admitted to the ICU. One of the most important things. Someone was asking yesterday about the mechanism of calcium. Mechanism of calcium, it is out of your scope. Just it is activating of some proteins and active enzymes, making it more active, especially the proteolytic enzymes that makes because the calcium is a common or a cofactor in activation of some proteolytic enzymes of the pancreas. So it is in a high concentration. It makes more activation and makes the condition more and more. Okay, makes the acute pancreatitis is common. Clear?
Yes, clear.
Next question.
A 50 years old woman attend her general practitioner due to a change in appearance. She finds difficulty removing board, an increase in shoe size, her facial appearance, direct conformation. Which of the following defect is most likely to be associated with her presentation? Binasal hemorrhagia, bitemporal hemorrhagia, inferior quadrant. Okay, I don't know the answer. I can't focus now. Sorry.
Okay, anyone can answer?
It is bitemporal hemorrhagia.
Bitemporal hemianopia.
So, pituitary adenoma.
Exactly, bitemporal hemianopia. We explained that yesterday. And we said there is a decussation. If we are just talking about decussation of the fibers, you can look like this. Okay, decussation of fibers. Say this is the eye, so this like this, like this. Okay, and you can imagine the fiber. We have two types of compression. We have compression from above, and we have compression from below. Okay, the below is the pituitary compressed from below, so it will block the decussation. So these two visions, these two sides will have a problem in vision, which is to bitemporal hemianopia, whatever the compression from above or from below. What is the difference? What will happen? The decussation when comes if I have this is the two visions. If I have these two visions, I have the fibers coming from below, make like this, and give me here like upper part if I make like this, and any fibers coming from above will go direct. This is a ball, will go direct to the lower quadrant. And we said if I have a compression from above, will affect these fibers, so will give me bitemporal hemianopia more on the inferior field. If I have a compression from below, it will give me hemianopia more, bitemporal hemianopia more superior field. Sometimes it's called superior, but you'll not find superior bitemporal superior by temporal quadranopia. Okay, clear?
This is clear, thank you.
Okay. I don't want us to take more time. Okay. Next question. Sorry again, sorry. Minute.
Anterior falls of the
Okay, next question.
A 24-year-old man fall off his motorbike, fracturing one arm, both femur, and rupturing his spleen. He required surgery and 20 units of blood. 24 hours after admission, he has passed 350 ml of urine. His blood pressure is 90/50, and he has low skin trigger. The juxtaglomeralar apparatus trigger. Okay, which of the following best describe the change in the renin angiotensin system initiated at the juxtaglomeralar apparatus in the patient? Okay, this patient have hypotension, hypovolemic. The renin should be high. The angiotensin 2 should be high. Aldosterone high. E.
Exactly. As you said, the renin angiotensin aldosterone system, the renin angiotensin aldosterone system start by renin. Substrate is angiotensinogen. Then so to the angiotensin, angiotensinogen, renin, angiotensin 1, angiotensin converting enzyme from the lungs, angiotensin 2, then angiotensin 2 go its effect. The most important effect is the aldosterone release and action on the distal convoluted tubule, or as we said yesterday, the aldosterone has three mnemonics or three sites of action. All they can be considered right. Okay. Aldosterone action. You can say, what's the aldosterone action? We can do like this. Make like this. This is the sites of aldosterone action. And this is the cortex, and this is the medulla. Cortex, and this is medulla. Sometimes he told you this is the action of aldosterone, and it tells you what is the site of action of aldosterone. Sometimes they say cortical convoluted, cortical collecting tubule, or sometimes it gives collecting tubule, or sometimes tell you the junction between the distal convoluted tubule and the collecting duct. So it works mainly on the junction here. So it can be cortical, it can be a junction, and it can be sometimes tell you directly the collecting tubule. Clear? This is the site of action of aldosterone. The other question coming in the exam is, what is the substrate for renin? Substrate for renin, angiotensinogen. Substrate for renin, angiotensinogen. Okay? Clear?
Clear.
Okay. Next question. Dr. Isra, last question.
Okay. A 35 years old woman presented to the emergency department with second attack of painful frag hematuria. What is the most likely pathology underlying this presentation? Gram-negative urinary tract infection, interstitial cystitis, renal cell carcinoma, transitional cell carcinoma of the bladder, urinary tuberculosis. It's painful. Does that mean infection? You say interstitial cystitis. B.
Exactly. Interstitial cystitis is one of the most confusing questions for all urologists we meet in the last few years since Fawzia Sheet. Sometimes some answered it. Some answered it gram-negative, and some answered it, but mostly answered and most common and the agreed answer is interstitial cystitis, as it is painful. So this is the most painful condition that can happen for a patient. If you search for TB tuberculosis, it will cause bleeding. If you can see here in the picture, this is a picture of interstitial cystitis, by the way. Hyperemia of all the superficial layer and the mucosal layer of the bladder with some petechial hemorrhage. And this is a chronic pelvic condition causing chronic pelvic pain. And here he told you this is a second attack, means if it is just an acute condition, maybe one. Once in the EMRCS tell you, or MRCS tell you, on second attack or third attack or repeated attacks, means the patient starts some sort of chronicity. Okay, some sort of chronicity. So this is the most accepted answer till now, and this is one of the most. But transitional cell carcinoma is not painful. Renal cell carcinoma is not painful. Even sometimes the infection is not so pain like inflammation. Sometimes like they rename it like inflammation like firing in the bladder. And this is in female patient, urologist can describe a female patient with interstitial cystitis. She is in severe pain, more than PID, more than any other thing. So here is painful, can give us this idea. Okay. Okay, who's next? Who can go?
A 60-year-old man presents with a short history of pain in the right cheek and the right upper teeth. Maxillary sinus infection is diagnosed. This sinus is particularly prone to infection of absence of cilia in the epithelium lining the sinus, closeness of sinus to the nasal cavity, poor blood supply, position of the sinus ostium high on the medial wall, and relationship of the front teeth to the floor of the sinus. My answer is D, I guess.
D.
Anti-gravity.
Position of the sinus ostium high on the medial wall.
Exactly. If we look here at the position of the sinus, you will find the position of the sinus is high up in the maxillary, space. And I said yesterday, I told you, if you check any CT, this is the problem why even if a patient has a facial trauma, and you make CT face and the patient has a maxillary fracture or intermaxillary bleeding, and by the way, it's very, very common in patient, very, very common. If you look to the CT for any patient has a maxillary trauma or something like this, you'll find this picture. For maybe unilateral or bilateral, you can find this picture exactly. Many times, if you just face, you'll see this picture. Whatever the patient was prone, the patient was whatever. After he did the CT, you will find this picture. Always you find like a line level in the CT of maxillary fracture of the patient. So that's why the maxillary sinus is here. So its evacuation in the nose is high. So it has a bad drainage. may exist. Not absence of cilia, not closeness of the sinus, nothing. The sinus is not close to the molar teeth. The first close is the first molar teeth or the molar teeth in general, the closest to the sinus. Others. Can anyone has noise background, please? Please.
मैं डेमो चलते हैं वहाँ पर अच्छे साउंड आता है.
Hello, we cannot hear.
Okay. You can hear me now?
Yes, yes.
Okay. So as I said, the picture of the okay, as I said, if you find a CT and for facial fracture, you will find it is always have what's like a fluid level in the maxillary sinus because it has ostium or the drainage is high up on the cavity. Okay. Next question, Dr. Muhammad.
A 75-year-old insulin-dependent diabetic man has undergone hemicolectomy. On the first post-operative day, he is nil by mouth on subcutaneous insulin, maintenance IV infusion with saline and intravenous morphine or patient-controlled analgesia. He is confused after a brief convulsion, has slurred speech, and weakness of his right side. His pulses is 110 beats per minute and respiratory rate of 25 breaths and blood pressure 160/95, SpO2 95% on room air. Most likely cause of the convulsion and confusion is hypoglycemia.
The option was
Hello?
So what's your answer?
Hypoglycemia.
Hypoglycemia. Exactly. This patient has the picture, as we said, is diabetic patient, diabetic man. The patient post-operative is still nil per mouse and taking only saline. How? Yeah, taking IV insulin and only saline. He didn't mention that the patient is taking dextrose. May the patient just give some units that equal to the 5% dextrose. Even in surgery, we don't accept D5 that can do anything in the blood glucose level because it's almost like a water. We give the patient like a hydration. Okay, so hypocalcemia is the most accepted. Patient will not have hyponatremia. As hyponatremia is a patient already is taking saline. Inhibition of adrenal take no. Delta receptor or GABA receptors, all of these can't evaluate or can't give explanation for the confusion except for confusion here, neurological condition and hypoglycemia. Okay, so this is a confusion and convulsions by hypoglycemia. So hypoglycemia is the most common cause in a patient MPO and is taking insulin and still MPO, and this is one of the most common mistakes in post-operative care patients during surgery, after surgery.
A 30-year-old
Okay, go.
A 30-year-old woman presents to the general surgical clinic with a 1.5 centimeter cervical lymph node along the anterior border of the sternocleidomastoid muscle. Clinical examination, routine blood tests are unremarkable. Undergoes an excisional biopsy of the lump as a day case. Histology reports an encapsulated infiltrative carcinoma with a marked fibrosis and cystic changes within the lymph node. What is the most likely primary pathology? My answer is papillary thyroid carcinoma.
Papillary.
My answer is papillary thyroid carcinoma.
Okay. So the patient is presented with cervical lymph node in the neck and histopathology encapsulated infiltrated carcinoma with marked fibrosis and cystic degeneration of the node. What is the most likely? Here is he's asking about the question, maybe any other cause, by the way, but here is the question is concentrating on papillary or thyroid cancer. Patient is concentrating in thyroid cancer. In the exam, you have two common questions, and he wants you to, or three exactly, and he wants you to differentiate between. From the scenario, he will give you the scenario straightforward. The scenario is straightforward. Most common is the follicular and papillary and the medullary. If he wants you to choose the follicular carcinoma, simply he will tell you the patient has a pulsatile. Patient has a pulsatile skull or bony lesion, and can give you a midline neck swelling, If he wants you to choose papillary, because why here? Because it is follicular, commonly blood spread. Okay, this is blood spread. If you want to tell you a papillary carcinoma, he will tell you the patient has lymph node in the neck, because papillary spread, can the patient has no lump in the, sometimes he mentions there's a lump in the midline of the neck, and sometimes they don't mention, and this is the most common, they don't mention any midline swelling in the neck, but he gave you the patient has a lymph node in the neck, and histopathology gives a picture of encapsulated infiltrate carcinoma or of thyroid. Sometimes they name it like cervical thyroid or metastatic thyroid tissue, more common and very early, before sometimes the mass in the neck can appear. It will be clearly the patient has cervical lymph node and analysis gives thyroid tissue, metastatic thyroid tissue. So it is papillary. Okay, tell me, doctor. Okay, طب ما أنا عندي I have the medullary. I have the medullary also spread by lymph node. Why I didn't choose medullary? Because nothing in the scenario can tell you the medullary. Medullary will be so clear. If he wants you to choose medullary thyroid cancer, it will be so clear. He will give you the patient, family history, sometimes family history. Okay, sometimes give you the patient has hypertension, unexplained hypertension in young age. So the patient has pheochromocytoma. or give you the patient has any picture of men too. Any picture of men too. The patient has a familial problem, like the patient has high parathyroid hormone. This is part of the men too. The patient has, sometimes tells you the patient has hypercalcemia. So hypertension, hypercalcemia. Sometimes tell you the patient has high calcitonin level. All these or any of them will be in the scenario. Family history, hypertension, hypercalcemia, men too, parathyroid or calcitonin. Sometimes give you calcitonin only. Sometimes give you parathyroid or tell you the patient has a parathyroid swelling. Sometimes tell you the patient has features of men too by any way of this. Sometimes he tell you the patient has hypertension, or he tell me the patient has hypertension, and by investigation he revealed to have pheochromocytoma and give it the question is more clear. So the question of medullary, very clear. Also, it is lymph node, but the history is very clear. Midline, neck swelling, and the patient has any picture of this. So all of this will be will target your mind to medullary. Okay, so doctor, okay, when I choose the other options like malignant lymphoma or like anaplastic, this will be a patient around 70 years and has neck swelling with adhesions with the neck, or mass. It will tell you the mass is highly stuck to the midline of the neck. So because it is highly infiltrated to the surrounding tissue very early in the disease, and will be give you the patient is 70 years. Okay, when he asks you, he wants you to suspect malignant lymphoma up to or upon Hashimoto thyroiditis. Patient has long history of Hashimoto thyroiditis plus hypothyroidism, and then the patient developed mass. What's your doubt? It will be malignant lymphoma on top of Hashimoto thyroiditis. So now we know when anaplastic, when follicular, when malignant lymphoma, when medullary carcinoma, and when papillary carcinoma. Clear? Shabab, clear?
Yeah.
Yes.
Okay.
Yes, clear, thank you.
Okay. So the answer here will be papillary thyroid cancer. Next question.
A 37-year-old man presents with a severe headache, photophobia, arid neck, stiffness, and Kernick sign is positive. And midline lumbar puncture is performed immediately to determine if a cerebrospinal fluid pathogen is involved. In performing this procedure, which is the first of the following structures to be pierced by the lumbar puncture needle? My answer is interspinous ligament.
Interspinous ligament. Okay.
Am I correct?
Yes, exactly. Okay, as we have interspinous ligament on the answer, so it will be the right. Normally in the exam, you will have 2 ligaments. 2 ligaments. When piercing the skin from outside by a venous needle, you will pass through skin, subcutaneous tissue, and then go direct to 2 important structure. If in the exam will ask you, so first one is supra spinous ligament, and very common in the exam. This is the first one, supra. First layer actually is the supraspinous ligament type. If I didn't find in the exam the supraspinous ligament, what can I find? Interspinous ligament. This is the second layer, and this is the first 2 layer will be preset after the skin and subcutaneous tissue. If I didn't find this layer, supraspinous ligament, my eye will go direct for supraspinous ligament. If I didn't find, the next layer is what? Interspinous ligament. Clear?
Yes, sir.
Clear. The other question will come to you, will ask about what is the most tough structure? What is the most tough structure?
Ligamentum flavum.
Ligamentum flavum. Very common part A and part B. In the exam, can ask you what is the most superficial structure, but this will be oral in part B. So supraspinous ligament. Next layer, interspinous ligament. What is the most tough structure? Is the ligamentum flavum. Ligamentum flavum is the most tough structure. Clear?
Can you tell me something about anterior longitudinal ligament and posterior longitudinal ligament, sir?
No need to be asked about. Wait. Some questions are out of scope. You will not be asked about the anterior and posterior longitudinal ligaments. Okay. Anterior and posterior longitudinal ligaments. This is maybe, I just draw picture of the, maybe this is a cut on the, rather, this is, here is the anterior. Here is the anterior. Here is the anterior spinal ligament. Okay, it is facing the abdomen. And here is the posterior spinal ligament. And here is the cord. Here is the cord. And here is the ligamentum flavum. Clear? Clear?
Yeah.
Yes,
Okay.
yes, sir.
Okay. By the way, in anatomy, especially in anatomy and all other branches, if you want to understand any issue, please don't hesitate to go direct to Google, search. It will help you so much in understanding this issue. Okay? Yeah. Next question.
A 26-year-old woman presents with a severe headache, photophobia, and neck stiffness. Among the other investigation, a lumbar puncture is found undoubted, and the cerebrospinal fluid is sent for microscopy and a culture. Culture shows a growth of Neisseria meningitis. What is likely to be the predominant cell types for the cerebrospinal fluid? Neutrophils. My answer is neutrophils.
Okay. Okay, as we said yesterday, again, in any normal infection like here, bacterial meningitis, as we see polymorphonucleoside. The same like any infection in the body, abscess, appendicitis, cholecystitis, diverticulitis, anything. The first thing you do is the total leukocytic count. You will find neutrophilia or polymorphonuclear leukocyte elevated. This will give you a sign of infection. In viral meningitis or encephalitis, whatever the viral infection, or in TB and brain abscess, sometimes cold abscess in the brain, you will not find the neutrophil. You see here up to 5,000, but here less, very minute numbers will not give you an indication, except bacterial infection is characterized by the polymorphonuclear leukocytosis. Next question.
A 70-year-old woman on a nursing home presents to the emergency department with an abdominal pain and vomiting. On examination, she is dehydrated and abdomen is distended. There is a 3 into 4 centimeter swelling in a right groin, which is non-tender, and there is no cuff impulse. At the operation, femoral hernia is found, which of the following lies medial to the neck of the femoral hernia? Lacunar ligament. My answer is lacunar ligament.
Okay.
Anterior inguinal, medial lacunar, lateral femoral, and behind posterior pectineal.
Okay. Lacunar ligament. Lacunar ligament, as we see here, lacunar ligament is the medial. The vein is lateral. Posteriorly is hello.
Conjoint tendon.
Posterior pectineal ligament.
Here,
Ligament,
lacunar. Here, pectineal. Here is the vein, and anterior is the inguinal ligament. Okay, very common question in the exam, asking about all borders. No exam without femoral canal. No exam without femoral canal. Next question.
A 26-year-old man presents to the emergency department with an extensive bleeding from his arm after sustaining a glass injury. On examination, there is a 7 centimeter transverse laceration across the anterior aspect of his elbow. On exploring the median cubital fossa, I would expect the brachial artery to be brachial artery lateral to the median nerve. My answer is
Lateral?
lateral to the median nerve.
You always ask in the cubital fossa. Always asking in the cubital fossa. The nerve is from medial, anterior, from lateral, anterior till medial. Now, in one exam last year, I think so, he gives the relation of the artery to the nerve. The same on the cubital fossa. So concentrate the exam. The artery is lateral in the cubital fossa. The nerve is medial in the cubital fossa. If you just put in mind lamb, lateral, anterior, medial, this is the nerve to the artery. Okay, so you in the exam concentrate. They now trying to change some questions. So put in mind to concentrate, because they know that is Fawzia sheet or this question are started to be leaked and many started to know it by recalls. So they want to check your concentration in the exam. Are you concentrate or you just know the question تحافظ الأسئلة كده بس. Okay, so so as we say, put in your mind the relation of the artery to the nerve or the nerve to the artery. So answer is medial. The answer is medial to the median nerve. D, yes?
No, lateral to the median.
Lateral
See.
to
Lateral.
median.
Lateral to the median nerve. The artery is lateral to the median nerve. Okay, next question. You want to go faster?
A 52-year-old man is found to have multiple myeloma. What skull X-ray appearance would be characteristic? Multiple osteolytic lesions would be the answer.
Multiple osteolytic lesions. Okay, this is a very important question and very common feature in multiple myeloma. Multiple osteolytic lesions. Multiple osteolytic lesion, as we can see in the picture here, is very common feature of multiple myeloma. Next question. Next question, please. Okay, continue till the question number 15. Doctor.
A 50-year-old woman present with a history of right upper quadrant pain and jaundice. She reports her urine was dark in color and that her stools are offensive and difficult to flush. What is the following of the following explains the dark urine? Increased conjugated bilirubinemia. A.
Increase in conjugated bilirubin. As we said yesterday, that Normally, you can find urobilinogen in urine, but in cases of obstructive jaundice, you have two things: conjugated bilirubin. If absent from the stool, it will give you clay stool, pale stools. If present in the blood, will be present in the urine, gives you the dark color of the urine. Can just rapidly, I just want to read the first 2 points here. Can you read it fast, please?
Urine bilirubin is normally absent, and when it is present, only conjugated bilirubin is passed into the urine. This may be evidenced by the dark colored urine seen in the patient with obstructive jaundice or jaundice due to HCC, hepatocellular injury. The lack of bilirubin in the intestinal tract is responsible for pale stools, typically associated with biliary obstruction. The cause of pruritus associated with biliary obstruction is the accumulation of the bile salts in the skin.
Okay, next question. And last question, then we choose another candidate to help us.
A 45-year-old man presents with a backache and leg pain due to prolapsed lumbar disc, lantovertebral disc. The pain is aggravated in the coughing and sneezing and radiates to the lateral aspect of the foot. On examination, there is a weakness in the plantar flexors of the foot, which now root is most likely to be involved. S1.
Okay.
Yeah.
As I told you yesterday, most common in the exam, he will ask you about L5 and S1. This is the most common, by the way. And L5 will be affected dorsiflexion of the leg, okay, and big 2. Dorsiflexion of the great big 2, sorry. Dorsiflexion of the big 2. L4 is responsible for dorsiflexion of the foot. S1, plantar flexion and lateral aspect of the foot. S1, lateral aspect of the foot. L4 will be medial aspect of the foot, and L5, dorsum of the foot. Most common in the exam, asking about S1 and L5. This is the most common. Also, dorsiflexion of the big 2 will be the L5. In plantar flexion will be S1, and this is associated with S1 dermatome, which is the lateral aspect of the foot. Very common question, by the way. You will find one or two questions about nerve compression, lumbar nerve compression, and Zika. As we know, all ankle jerk, S1, S2. Mainly S1. Knee jerk, L3, L4. Mainly L3. Clear? Next question, I want new candidates to share, please. Dr. Dafer, are you ready?
Sir, can you please add Fahida?
Sorry?
Can you please add a participant named Fahida?
Yes, admit, okay. Added.
Thank you.
Welcome. Okay, Dr. Dafer, are you ready? Okay, who's ready to continue the next 5 questions, or as he can, 10 questions, no problem. Dr. Ahmad Az?
Yes, hello.
Hello, Dr. Ahmad.
Hello, Dr. Ram.
Okay, are you ready to read the next 5 or 10 questions?
I entered late, but I was surprised when you restarted again from the first question.
Yeah, because record yesterday, it wasn't so good. And so I tried to finish all this so fast as we can. So I need anyone to read at 10 questions. We can go to get direct, no problem.
Okay, I will start with question 16.
Yes.
Okay. A 62-year-old woman presents to her general practitioner with a 2-week history of back pain. She has lost 8 centimeters in height over the last 5 years. Investigations reveal calcium is high, 2.78. Phosphate is normal. GFR is normal. Parathyroid hormone is high, 8.9. So this is primary hyperparathyroidism because the parathyroid hormone is high and the calcium is high.
Okay. Primary hyperparathyroidism. And we explained this yesterday again. If you have high calcium.
Again, sorry? High calcium, high parathyroid hormone. This means that's primary hyperparathyroidism.
Yes.
High parathyroid hormone, low calcium, secondary hyperparathyroidism. Very high parathyroid hormone and high calcium and high phosphorus. This associated with the chronic renal liver disease, tertiary hyperparathyroidism.
Exactly. Excellent, Dr. Ahmed.
Thank you.
Next question.
A 21-year-old man fractures his ulna and radius. He is treated by means of plaster cast, which is removed after 4 weeks. What pathological process is most likely to have affected the immobilized muscles? Disuse atrophy. It's called disuse atrophy when it's not using the muscle too much to make atrophy.
Exactly. Like Sudokus atrophy, sometimes the Sudokus syndrome or Sudokus atrophy that happened in long casting for a limb and can cause some sort of contraction that happened. But no hyperplasia, no hyperplasia, no hypertrophy, no neoplasia or aplasia, all these completely different conditions that can happen. Okay, next
I was inquiring about the time. 4 weeks is enough to cause atrophy of the muscles?
It is not actual complete atrophy. It is some sort of atrophy to the cells. And the cells, like those who are playing gym or playing sports, the muscle after it's some sort of hypertrophy happened to the muscle due to training. And if he stopped training, what will happen is called atrophy. Atrophy, not dead, just get smaller in size. And by training, can go back again. That's what happened to the muscle. That happens with what's called Sudokus atrophy, and the patient can start to have physiotherapy for a long time to return the muscle bulk again.
And the atrophy reveals that there is a decrease in size, but not impairing function.
No, not permanent function.
Yeah.
Not permanent function.
Not impairing function. Function is good.
By physiotherapy, it can go back again to normal.
Yeah, okay, thank you. A 22-year-old man has been stabbed in the left fifth intercostal space at the edge of the sternum. Which structure is most likely to have been penetrated? Left fifth, right ventricle. If it's right fifth, it will be the right atrium. If in the mid-clavicle line, left fifth, it will be the left ventricle.
So your answer is right ventricle?
Right ventricle, yes.
Okay, exactly. As we see here, we explained yesterday.
Yeah.
The right atrium is on the right border, border of the sternum, present by all this, the right atrium. Okay. The left atrium, the right ventricle on the left side of the sternum. If he told you in the mid-clavicular space, mostly you will injure the apex, but the question almost always come right or left parasternal on the left side, on the fifth intercostal space, and this injure the heart. Sometimes if he told you fracture of sternum, and I think in the fracture sternum, like Dr. Ahmed asked yesterday, this is the right ventricle, almost will be like this. Sorry,
Right atrium.
Exactly, right atrium.
This is a September 2020 question. External fraction.
All presented on the right atrium, presented behind. You have many photos, by the way. If you Google, you will find many photos about this.
Okay. An 80-year-old man dislocates his shoulder. It is reduced in the emergency department at review. 3 weeks later, he is unable to actively initiate abduction of his arm, which muscle most likely damage. This the initiation of abduction from 0 to 15 is the supraspinatus muscle, C.
Okay.
Supplied by the suprascapular nerve, deltoid muscle from 15 to 90, and supplied by the axillary nerve, and the trapezius and serratus anterior from 90 to 180, and this will be suprascapular nerve for the spinal accessory nerve for the trapezius, and long thoracic nerve for the serratus anterior.
Okay. As we said here, from 0 to 15, as we said, supraspinous nerve. Supraspinous nerve, initiation of abduction. If he tell you 0 to 100, 16 to 120, it's called painful arc or impingement syndrome. Impingement syndrome. Both of these or supraspinatus tendinitis. All this due to subacromial bursa, because the supraspinatus tendon pass below the acromial, and there is here a small bursa. When it is inflamed, makes this arc from 60 till 120 is very painful. Okay. So answer here is supraspinatus.
Yes.
Next question.
An 8-year-old boy is admitted for assessment of rectal blood loss. His mother describes this as bright red blood in the toilet pan. He has no pain on defecation. There is no family history. What is the most likely cause? This is juvenile polyp.
Juvenile polyp.
Most common in this age.
As you said yesterday, if you want the same, juvenile polyp is also associated with Pitt-Jigger syndrome, but he would mention for you pigmentation. Pigmentation perioral or any other body pigmentation, but this is the most common. If he asks about pigmentation or any teeth problem or something like this, you will go for Pitt-Jigger syndrome. If just said a polyp, so this is a juvenile hamartomatous polyp. It is not an adenomatous polyp, it is hamartomatous polyp that cause this problem. Next question.
A 48-year-old woman presents with abdominal pain and 5 to 6 episodes of bloody diarrhea each day. She also complains of pain in the knees and elbows and recent visual problems. What is the most likely diagnosis? This is extra-intestinal symptoms of ulcerative colitis.
Of inflammatory bowel disease, but it is more inflammatory bowel disease. Take care. Okay, so this is ulcerative colitis. Take care of this, that the extra inflammatory or the extra intestinal manifestation complaining of arthritis, very common question in the exam. He wants you to confuse between arthritis and arthritis. If you are in the exam not concentrating and not sleeping well, you will go for this, and this is completely wrong. Extra external manifestations, complete polyarthritis. That's why here it's pain in elbow and knees. Always remember, any patient or your friend who has ulcerative colitis or Crohn's disease, he will tell you, I have knee pain or elbow pain or back pain. Actually, I have a friend have this problem, and he always complaining of knee or elbow or sometimes low back pain. But no polyarthritis. This is polyarthritis plus stomatitis and cholangitis, uveitis, and red eye. Sometimes he tell you also the patient has visual problem or a red eye. Next question.
A 56-year, if anyone want to share, just tell me and I can stop. A 56-year-old man.
Till 25. Finish till 25.
Okay. A 56-year-old man presents with acute epigastric pain and vomiting. On examination, he has guarding in the upper abdomen. Investigations reveal amylase is high, 900. Okay. And LT high, like campus is almost normal. Albumin is normal. Gamma T normal. Bilirubin normal. Trials normal. Calcium is high, 3.3. Which of the following is the most likely etiology of this condition? This is the hyperparathyroidism causing hypercalcemia, causing acute pancreatitis.
So your answer is?
Hyperparathyroidism, C.
Hyperparathyroidism. As we explained in the first question, that high calcium level is a cause of acute pancreatitis, but hypocalcemia is a result of acute pancreatitis. Okay, and as we explained, maybe you are late, and we said that why hypercalcemia? Because calcium enter in activation cascade of some proteolase enzymes, in the pancreas, and so these proteolase enzymes can cause damage activated by the high calcium. It is more activated to cause damage of the pancreas.
A 30-year-old man is admitted to the intensive care unit with an isolated severe head injury. Isolated. A CT scan shows multiple intracerebral bleeds, but no midline shift. He is intubated and ventilated. His pupils are dilated and reacts sluggishly to light. His heart rate is 50 bradycardic. Blood pressure is 170 over 110 hypertensive, and his respiratory rate is set to at 10. The rising blood pressure is likely to be caused by this Cushing triad with sympathetic stimulation related to intracranial pressure, E.
Exactly, sympathetic stimulation. As we said, what happened in Cushing triad is sympathetic stimulation due to increase the intracranial pressure, compressing the arterial structure, so making some sort of brain ischemia. So the heart or the ischemia will be felt by the body regulating mechanism, will make hypertension, trying to increase the blood pressure to overcome the compression by the intracranial pressure. So hypertension will happen. When hypertension is happened, there is felt by the baroreceptors, stretch of the baroreceptors in the aortic arch and in the bifurcation of the carotids, and will have reflex bradycardia for the hypertension. And this is the Cushing triad. This is the Cushing triad, and we said you have to concentrate in any accident, patient in any accident. If the high blood pressure and low pulse and irregular respiration, so this is a Cushing triad, Don't mix if he told you low blood pressure and tachycardia and respiration with tachypnea. This will be patient shock or hypovolemic shock. Hypovolemia. Okay, hypovolemia. Next question.
A 42-year-old multiparous woman is admitted to the emergency department due to pelvic discomfort. The duty gynecologist diagnoses uterine prolapse, which anatomical structure gives significant direct support to the uterus. The answer is E, transverse perineal muscles.
Very common question in the exam. I don't know why they like it. And even in the recalls, the last 2020 September recall, someone said, you will find all answers is ligament except for one muscle or one tendon. Sometimes transverse perineal muscle or sometimes transverse perineal tendon. Both are right, the main support of the uterus. Next question.
8-year-old man is admitted to surgical admission unit with central abdominal pain. His blood pressure is 100 over 60. His pulse is 110 with a respiratory rate of 25 per minute. He is known to have severe chronic obstructive pulmonary disease, COPD, and has been a heavy smoker all his life. On examination, he has a rigid abdomen. Arterial blood gases show the pH is acidotic 7.2. Oxygen is 9, hypoxic. Carbon dioxide is 5.3, normal. The bicarb is low, 17. Base axis is -3. So this acidosis and bicarb is low, so it's metabolic acidosis. And due to surgical admission, abdominal pain, I think it's peritonitis, so the answer is C.
Okay.
And for anyone who go first time for the exam, this is the way they are misleading us with information to mislead you, like the COPD and heavy smoker.
Exactly. Here is he wants you go for the pH. By the way, you have about more than 10 questions for ABG in the exam. And you have to know to the thus pH. This is acidotic. Then go. CO2 is not in the acidosis, so it is not respiratory, but bicarb is acidotic. So it is metabolic problem. Is the metabolic problem due to COPD? Is COPD making a metabolic problem? Actually, no. So my choices is between these two. And we don't have COPD causing metabolic, so it is a metabolic acidosis due to peritonitis.
Like if he said respiratory acidosis due to COPD.
Yes, respiratory acidosis. You'll find this 8 مثلا, this very high, and this will be almost normal.
Normal, yes.
If the acute COPD, you will find this high, around 30.
Yes.
Okay. If it is a chronic respiratory problem, mostly you will find the CO2, you'll find it high. Bicarb, you find it high. Because renal compensation starts after 48 hours, and then the kidney will start to add bicarb to neutralize or to compensate the CO2, high CO2. But if it is acute respiratory problem, by the way, if anyone has a problem with ABG, we can manage in between a small lecture for ABG. If the patient has a small acute respiratory condition, like morphine, patient is taking morphine post-operative, and the patient, you will find the CO2 is high, but you will find bicarb is normal. And then in the choices, you will find COPD or respiratory depression due to morphine. Go. This is chronic condition, this acute condition. What will make difference in the exam or in the choices? Go for the bicarb. If the bicarb is normal, so it is acute condition. If the bicarb is high, so it is a chronic condition. And this is differentiate when you choose the answer between the two answers. This will differentiate for you the condition.
And when it will be mixed if the bicarb and the carbon dioxide high and bicarb is low.
And both of them, no, both of them in the same way. So you have acidosis and you have high CO2 and you have low bicarb.
This mixed.
Low bicarb. So this is a mixed condition.
Okay, great.
You want to continue, or anyone want to say, Dr. Dafer, you want to share? Anyone wants to share?
Yeah, I'm ready.
Okay, Dr. Dafer, go for the next 10 question, please. Thank you, Dr. Ahmed.
Thank you, Dr. Rami.
Thank you, everyone. Hi, everyone, and thank you for Dr. Rami. Question 26. In describe the sinoarterial node, which one of the following statement is correct? Is a part of the somatic nervous system. It is usually supplied by the left coronary artery. If it's lie in the wall of the left atrium, it's lie in the wall of the right ventricle. It received fiber directly from the vagus nerve. So it's E.
Exactly. We said yesterday that we said that the SE node and the AV node receives autonomic, not somatic. Autonomic is completely wrong. It receives autonomic nerve innervation from the vagus nerve and from the sympathetic cervical or dorsal sympathetic plexus. Only receive autonomic response, no somatic innervation for the heart, no somatic innervation for the autonomic system of the heart or the regulatory AV node and SE node of the heart. They only received autonomic nerve supply from vagus that makes bradycardia and from dorsal sympathetic plexus that cause tachycardia. Next question, Dr. Dafer.
Yes. A fit 21-year-old man admitted with the acute abdomen, subsequently diagnosed as gastroenteritis, apart from host immune response. Which of the following immunoglobulin and cell are correctly paired? Immunoglobulin A with macrophage, immunoglobulin D, the small bowel epithelia, immunoglobulin E, endothelial, immunoglobulin G with plasma cell, immunoglobulin with thymocyte. So it is D.
Okay, as you said yesterday, if you have to go, this is a not frequent question, by the way. It doesn't repeat again since 2016, but I think it's also present in EMRCS, and it will also come with this question, IgG with plasma cell. Don't go deep to go for immunoglobulins and this. If I found a table for everyone and from which cell it is associated, I can send you, but mostly I tried to search before, and I just found about IgG and plasma cell are related to each other. And I think we can remember, I think from our studies, that IgA is present with the, I think, the bowel, small bowel epithelium. I think IgA is concerned with this. But as we said, many questions in the MRCS, you have to know without details, because this question has no other related questions. Just come alone, single question with no other. Others can be changed, like the thyroid question. He can ask many questions with different scenario, but this has only one scenario. Okay, next question, Dr. Dafer.
Yes. 45-year-old man presented with a fever and pain in the right loin and groin. Soft swelling was noted in the femoral triangle. Diagnosis as psoas abscess was made. Which of the following statements is mostly accurate regarding the psoas major? It arises from the lateral border of the body of T12 L5. It's extended the hip. It's inserted in the great trochanter of the femur. It's innervated from the T12 and L1. It's passed posteriorly to the capsule of the hip joint. So it is A.
Okay. As we said yesterday, this is one of the main flexors of the hip and sometimes the internal rotators. It is inserted in the lesser trochanter, innervated by, I think, L1 to 3. It is not, didn't ask it before. And it passes anterior to the capsule of the hip joint. So the answer is A. It arises from lateral border of T12. Next question.
Okay. Which of one of the following muscles is extensor of the hip? Adductor longus, gracilis, iliopsoas, pectineus, semitendinous. Semitendinous, yes.
Semitendinosus
Yes.
is one of the main extensors of the hip, as we see here. Flexor of the hip and extensor of the hip are the most common question coming. Gluteus maximus, sometimes and medius also make extension, but here is he mentions the main muscles for extension is the gluteus maximus and hamstring muscles. The flexors is the psoas major, as we said, up iliacus, pectineus, and all the small muscle rectus femoris as well, because it has two heads. One of them can help in flexion and sartorius muscle. So flexors and extensors, this is the most important you have to concentrate in. Next question.
A tall, thin, 25 years old woman presented to the surgical clinic with the complaint of swelling in the front of the cheek. From the last 4 months, a clinical examination, she has a swelling in the left lobe of the thyroid, multiple numerous lesion with an oral cavity. Her blood pressure 220 over 120 millimeter mercury. Laboratory investigation show there is high calcium and electrolyte and normal serum calcitonin and urine van mandelic acid level are elevated. Which of the following is the most cause of the hypertension? So it is a part of the main Cohn syndrome, Cushing disease, essential hypertension, pheochromocytoma, and renal artery stenosis. So van mandelic acid elevated with the pheochromocytoma.
So the diagnosis here of this thyroid swelling is
multiple endocrine neoplasia type 2B, and it is a pheochromocytoma.
okay. This is the answer is pheochromocytoma, and he is describing a thyroid swelling here. What is the thyroid swelling will be?
Medullary, yeah.
Okay. Medullary thyroid carcinoma. Medullary thyroid carcinoma. He, as we said, when he wants you to ask about medullary, sometimes he change all these. Sometimes he change all these answers and ask you what is here is which of the most likely cause. Can not give this. It will be in the exam. He will give you medullary thyroid cancer. But if what is the most common cause of hypertension, it will be pheochromocytoma. What will be the most common cause of his high calcium level? Here is no calcium. I told you here no normal calcium. Calcium is normal. But sometimes if you want to change the question and what he is doing now, it's getting the same scenario with different answer. And they give me the patient has a high calcium level. So what is the main cause of the high calcium level? It will be hyperparathyroidism. Hyperparathyroidism, because main two is parathyroid hyperplasia, medullary, and pheochromocytoma. Take care about this question. Very common. If you want to ask the medullary, he will give all the syndrome. He only asked, by the way, in MRCS, only ask about the medullary in MEN2 syndrome. He will not give you a sporadic medullary thyroid cancer. He will not ask you about a sporadic مدرس, we want you to know the basics. Next question.
65 years old man presented with the hematuria on left line pain. Computer tomography and demonstrated of the left renal tumor. He's undergo left renal radical nephrectomy. Where does not the left renal artery lie? Anterior to the left gonadal vein, anterior to the left renal vein, anterior to the splenic vein, posterior to the left renal vein, superior to the superior mesenteric artery. So it's D, posterior to the left renal vein.
Okay, straightforward question. The relation between the renal pedicle, as we said yesterday, it is VAP from anterior to posterior, vein and then artery and then pelvis from anterior to posterior. VAP from anterior to posterior. Very common, he asks you where is the pelvis, where is the artery, relation to the artery to the vein. Just put VAP in front of your eyes and then choose direct what is the relation between these structures. Next question.
Within the posterior triangle, which nerve has a particular risk damage during the surgery? Aurical branch of the facial, glossopharyngeal, phrenic, and recurrent laryngeal, and the spinal accessory. So it's E, spinal accessory.
Spinal accessory, as we said yesterday. And it is root of spinal accessory.
C2, C3.
2, 3. Okay. In the exam, mostly posterior triangle injury. This is very common question in the exam. Spinal accessory. This one was a question in the exam, just less than 10 seconds. Most common structure injury in the posterior triangle, it will be spinal accessory. No other structures he will ask you about. Next question.
Okay. The right and left pulmonary artery are derived from which of the following embryological aortic arch? Second aortic arch, third, fourth, and the fifth or sixth aortic arch. So it is the sixth aortic arch.
6 aortic arch. Again, we didn't align yesterday. We said that we have two important branchial, or sometimes branchial arch or aortic arch or branchial clefts. Very important too. Second, it gives us 7th cranial nerve, which is facial, and give us stapedius muscle, stapes, or S. So second branchial arch is with 7s, all 7, stapedius, stapes, 7s, or second, all from the second pair. The other one is the 6th arch. This will give you vascular structure, asking about, sometimes give you the pulmonary trunk, sometimes tell you the pulmonary trunk, pulmonary artery, or recently ductus arteriosus. 6 will give you this, second will give you this. Others never came before, but if you want to know more, just know the first to give you muscles of mastication, maxillary, and so on. This is the mandibular, give you the mandibular portion, and muscles of mastication is from the first branchial arch. If you want to know more, know the first, give you the mandibular arch, the mandibular nerve, and muscle supplied by the mandibular nerve mostly the muscles of mastication. By the way, here will give you the facial muscles, facial nerves, and gives muscles for facial expression. Second is responsible for muscles of facial expression. The first is responsible for muscles of mastication. Next question, very important.
Yeah. A 47 years old man presented to emergency department 6 hours after climbing accident. His initial assessment suggested that he had lost 1 liter of blood. His blood pressure 105 to 70 millimeter mercury, and his pulse rate 88 beats per minute. He is catheterized and his bladder contained 120 ml of urine. Activation of which of the following transport system best describe how aldosterone needing to maintain of intravascular volume and oliguria in this man? Sodium glucose in the proximal tubule, sodium hydrogen ion in the descending loop of Henle, sodium and potassium in the ascending loop of Henle, sodium and chloride in the distal tubule, sodium, potassium in the collecting duct. So it's E.
Exactly. Explained yesterday again, and I told you this picture is very important, part A and part. Okay, here is loop diuretics act on sodium potassium 2 chloride, sodium potassium 2 chloride, and responsible for absorption of up to 25%, or sorry, excretion of 25% of sodium. That's why loop diuretics is very strong antihypertensive. The other is Sayazid diuretics, and responsible for missing 5% of the total sodium absorbed, and it work here is worked on loop diuretics on thick ascending loop of Henle. So you have to know the site of action, the mechanism of action, and the name of diuretic. Very important, this table. The other thing is Sayazid diuretics working distal convoluted tubule and sodium chloride. Here is sodium potassium 2 chloride, 2 positive and 2 negative, 2 chloride. Here is 1 positive only, so it will take only 1 chloride. So sodium chloride and give -%. And the least or the least strong antihypertensive drug is the calcium is the aldosterone or potassium sparing diuretic, responsible only for 1 to 2% only of sodium, and it works on sodium potassium pump. Site of action, as we said in the start in our lecture, site of action sometimes tell you cortical collecting duct, and sometimes tell you on the collecting duct, and sometimes tell you on the junction between the distal convoluted tubule and collecting duct, collecting tubule or collecting duct. The 3 site of action are the same: cortical or collecting duct, or the junction between the distal and collecting duct. Very important picture you have to keep in your mind till you finish your MRCS. Okay, next question.
During arch aortogram, the vertebral artery would be seen in arising directly from which of the following? Arch of aorta, brachiocephalic, common carotid, internal carotid, and the subclavian artery. Subclavian artery.
Subclavian artery. This is anatomy and straightforward question. Very, very common question. Internal mammary and the internal mammary and the vertebral artery. Very common to give you a long scenario about the vertebral arteries that go which opening and then ask you about the origin of the cerebral artery, of the vertebral artery. Okay, next question.
A 65 years old man remain on the high dependence unit following gastrectomy. 3 days previously, his urine output has averaged 80 ml per hour. For the last 24 hours, he is on 1 day abdominal drain and abdominal drain right, no nasogastric loose. His urea and electrolyte are normal. He is to stay nil by mouth for further 24 hours. Which of the following fluid regime must appropriate to electrolyte and water requirement over next 24 hours? 1 liter of the 9% saline plus 1.5 liter of the 4% dextrose, 0.18 saline, 1 liter of the normal saline plus 1.5 liter of the 5% dextrose, 1 liter of the normal saline plus 1/2 liter of the Hartmann, 2 liter of the normal saline, 2 liter of the 4% dextrose, and 0.18 saline. So it is B. Saline and dextrose.
Exactly. As we said, normally inpatient, post-operative, we give him half the amount of fluid he will take, saline, and double or 1/3 of the fluid he will take. Give us saline. Sometimes you give 1 liter saline and 2 liter glucose. And as I told you yesterday, that is dextrose. This is the water the patient will drink, but you'll give it IV fluid, just 5%. It is not considered a percent. Even diabetic patient, it will not affect his random blood sugar. And we have to give this patient and give the patient on normal. So here is very accurate to tell you no nasogastric loss, because if there is no nasogastric fluid loss, we always replace this with
Hartmann
solution. Exactly. So if he tell you this, but it will not, forget that I said this. We always in surgery, if the patient has fistula or if the patient has nasogastric tube and he has some losses of the GIT contents, we replace it with Hartmann solution or Ringer solution. Next question.
A 3-year-old boy is admitted to the hospital with a severe vomiting. Radiological examination revealed that he's suffering from the annular pancreas, which of the structure is constricted. So first part of the duodenum, second part, the third part, proximal jejunum, and pylorus of the stomach. So it is the second part of the duodenum.
Exactly. This is a straightforward question and very common in the exam. Annular pancreas makes constriction in second part, and this is a site of opening of the pancreatic duct as well. Next question.
20-year-old with severe head injury is being ventilated using intermittent positive pressure. Which of the following physiological consequence of this? Decrease extracellular fluid, extracellular volume, decrease cardiac preload, increase intrathoracic blood volume, increase cardiac preload, increase cardiac stroke volume. So it's B, decrease cardiac preload.
Decrease the cardiac preload. As we said in the first in the question of Valsalva maneuver, we said that anything increase the intrathoracic pressure will decrease the venous return. So this will decrease the cardiac preload. Cardiac preload means is the venous return. We said patient and intubation onto positive or intermittent or continuous positive pressure, or the patient has Valsalva maneuver, the patient has hemopneumo or pyothorax, or making physiologically Valsalva maneuver, this patient will increase the intrathoracic pressure, and any increase in the intrathoracic pressure will decrease the venous return, because it will decrease the negative pressure inside the thorax, which is responsible for the venous return. If it is decreased or lost, it will decrease the venous return. Decreasing the venous return will decrease the cardiac preload. Okay?
Okay.
Next question.
Okay. 36-year-old man presented with a 2-month history of low back pain related to the left leg. After a clinical examination, he is referred from MRI scan. This show prolapse intervertebral disc. The clinical sign are consistent with the pressure of the S1. I cannot.
Sorry.
Yeah. Okay. Don't worry. S1 root. Which combination of clinical sign is most likely? So S1, weak ankle plantar flexion, halter sensation in the dorsum of the foot. No. It's weakness ankle plantar flexor. Okay. Alteration sensation of the sole of the foot. Okay. And loose of the ankle jerks. Yes. It's B. Because the other those the flexion.
Just when you start, hallux dorsiflexion, hallux dorsiflexion, hallux dorsiflexion, all this L5. All this L5. We are talking about plantar flexion. Okay, so by exclusion, we have the first two choices and then continue. Alter sensation on dorsum of the foot. We said dorsum of the foot is, as we explained, L5, but here is and normal ankle reflex, completely wrong. So my answer will be, here's as we said before, S1 will be responsible for the ankle plantar flexion, will be responsible for the ankle jerk, and will be responsible for the lateral aspect of the sole. As we say here, as we see here, this is very nice picture for L4, L5, S1 compression. And if we can see S1 lateral aspect of the foot, it will be responsible for the ankle jerk, and it will be plantar flexion of the foot. Not any plantar flexion of the big toe, it is not very common. As more important is the dorsiflexion of the big toe, which is the L5. Dorsiflexion of the foot is L4. Clear?
Yes.
Okay.
Okay.
Next question, we arrived yesterday. No, we didn't say this yesterday. This is to now. We'll start again the new question because those who didn't attend yesterday can complete with us. Okay? Yeah.
Okay.
Go.
55 years old woman undergo a cholecystectomy. The gallbladder contain multiple dark, irregular small stone. The most likely cause for this type of the gallstone is increased by the bile salt, calcium, cholesterol, and conjugated bilirubin. So it is unconjugated bilirubin E.
Unconjugated bilirubin is responsible for the multiple dark stones, pigmented stones on the body because of unconjugated bilirubin. That's why we find it in those who have blood, hemolytic blood disease, like sickle cell anemia and spherocytosis or thalassemia or something like this. We just have a patient in our hospital 2 days ago, and we did cholecystectomy today. A young boy with abdominal pain, and we found this boy has multiple small gallbladder stone, and we did cholecystectomy yesterday, dark, and this patient is now investigated by internal medicine to know what is the cause of his hemolytic blood disease. Yani mostly more than 9% this patient will have a hemolytic blood disease, maybe in a certain degree, maybe minor degree, but with age, he will have multiple gallbladder stone because high unconjugated bilirubin will cause this. Most common gallbladder stones is mixed stone. Very common question as well. The most common is the mixed stone. Mixed stone is the most common gallbladder stones. Okay, who can start again? Who can continue? Raise hand, please. No, we want more to share, please. Just go for the next 5 questions.
I'm ready.
Okay, Dr. Ahmed. Then Dr. Ahmed, then Dr. Omar.
Okay.
Then Dr. Okay. Start, Dr. Ahmed.
55-year-old man presents with a deep venous thrombosis. His full blood count shows a hemoglobin of 18.3 gram per deciliter, a white cell count of 8,000, and platelet count of 200,000. Normal. This hematological picture is most likely be associated with deep venous activity. Hemoglobin is high.
This patient has polycythemia, increasing the blood viscosity, making him deep venous thrombosis and making him high hemoglobin. What do you expect?
This something in the kidney, but renal cell carcinoma, because transverse cell carcinoma of the kidney is affecting the pelvis of the kidney and it's not affecting the parenchyma and the nephrogenic function of the kidney. So it will be renal cell carcinoma, adenocarcinoma.
Okay, one of the most common paraneoplastic syndromes.
Hamza. Ya Hamza. Ya hala.
Okay, one of the most common paraneoplastic syndrome. By the way, during our recall sessions, the next few weeks, you will find very common paraneoplastic syndrome associated with every disease or every cancer. Renal cell carcinoma may have many paraneoplastic syndromes, but polycythemia is the most common, and this is the explanation of erythrocytosis and polycythemia in renal cell carcinoma. Can you read, Dr. Ahmed, please?
Renal cell carcinoma is associated with a wide spectrum of paraneoplastic syndromes occurring in almost 10 to 40% of patients with renal cell carcinoma, including erythrocytosis, hypercalcemia, hypertension, and metastatic hepatic dysfunction. erythrocytosis اللي هو زي الصورة بتاعت يعني like this question. Renal cell carcinoma is the most common cause of paraneoplastic erythrocytosis. Occurs in 3 to 10% of patients. May result either from enhanced production of erythropoietin from the tumor or as a consequence of renal hypoxia promoting erythropoietin production from non-neoplastic renal tissue.
Okay, so if you find polycythemia in a paraneoplastic syndrome, questions are straightforward. Search directly for renal cell carcinoma. It is the only paraneoplastic syndrome and the only couple you will find together, polycythemia and renal cell carcinoma. Next question, Dr. Ahmed.
Okay, so I'm writing this my note.
If you want, I will continue.
Dr. Ahmed, just finished 5 questions at least.
Okay, 27-year-old has had pancreatitis for the last 5 years. Which one of these complication is the least likely to develop? Least likely. Pancreatitis. Arthritis, meningitis, otitis, this is talking about the extra-intestinal manifestation of inflammatory bowel disease, which is not including the polyarthritis. Arthritis, cholangitis, arthritis, and toxic megacolon are all from the extra-intestinal manifestation of arthritis. So the answer is D, polyarthritis.
Okay, this question depends on the concentration. Really, if you're not sleeping well, you will get confused between arthritis and arthritis. Polyarthritis, talk to the age of the patient. So the patient has an inflammatory bowel disease, whatever it is, Crohn's or ulcerative colitis. Polyarthritis is not included in the extra-intestinal manifestation of inflammatory bowel disease. Next question.
A surgeon makes a phalangeal incision for access to the pelvic organs. He incises the abdominal wall down to and through the rectus sheath. He reflexes the rectus abdominis muscles laterally from the midline to expose the below the arcuate line. It will be only the transversalis fascia and peritoneum.
Okay.
So the first to be the transversalis fascia, then the peritoneum. And if you don't have transversalis fascia D in the answers, I will choose peritoneum P.
Exactly. Here you finish till incision at this line below, as Dr. said, below if we have this rectus, okay, below the arcuate line, we have only anterior rectus sheath. And then when you cut the anterior rectus sheath and go for splitting of the recti muscle, you will find just below, directly here, you will find the transversalis fascia. It's actually, it is adherent with the peritoneum. Okay.
A 25-year-old man undergoes splenectomy.
Okay. Sorry, Dr. Ahmed.
I'm proceeding with other than the 44 question.
Okay, just give me, just will take 2 minutes break. Okay, and then back. Keep on. Just 2 minutes break. Okay.
Okay. Stop recording or keep recording?
I just pause. Okay, back again. Okay, Dr. Ahmed.
A 25-year-old man undergoes splenectomy following blunt abdominal trauma. 3 days post-operatively, venous blood testing is likely to reveal a high platelet count, A.
Exactly. This is one of the most common cascades that happens post-splenectomy is thrombocytosis, and then the patient will suffer from thrombocytopenia, but later on, I think after a few months, but early post-operative blood picture patient of splenectomy, you will find thrombocytosis or high platelet count. Okay, and here is the most common causes of thrombocytosis. Number 3 is the post-splenectomy thrombus in the first few weeks.
Can you explain?
Months. The spleen is responsible for breakdown of old-aged platelets. And in post-splenectomy patient, till the body start regulation, the patient will have thrombocytopenia in the first few weeks up to few months. Simply, and this question has no explanation. One of the question of the single question has no explanation, has no coupling with any other question. Okay, next question, Dr. Ahmed.
A 46-year-old woman is seen in the pre-admission clinic. She had a myocardial infarction 2 years ago. On examination, she is in atrial fibrillation, and a recent echocardiogram shows that she has a dilated left ventricle. She is on warfarin, and her INR is 6.1. Warfarin inhibits which of the following? Warfarin is acting on the prothrombin. D.
Okay. Simply warfarin acting on the prothrombin. As we see here, warfarin is acting on the prothrombin.
Extrinsic pathway.
Extrinsic pathway. As we said, warfarin and heparin. Warfarin acts on the extrinsic pathway, and if you want to remember, okay, we can say that warfarin and heparin. Warfarin, we take it oral, so it is externally. Okay, so it acts on the external pathway, and it is controlled by prothrombin time and INR. INR is a ratio between PT over PT, normal PT and over index APT. So this is INR. So you can control warfarin by the PT, and then it is reversed by vitamin K, fresh frozen plasma, and prothrombin complex concentrate. It is the main 3 components that you have to reverse with warfarin. Warfarin, by the way, crosses the placenta, and it is contraindicated for pregnant women because it is teratogenic. Okay, heparin, we take it IV, so it acts on the internal pathway, intrinsic pathway, and it is controlled by intrinsic and common, by the way. Both of them acts on the common, and it is controlled by PTT, and the reverse is with protamine sulfate. Okay, very important table, but you have to remember just warfarin. We take it oral, so it acts on the extrinsic because this is like an extrinsic medication. We take it IV, so it's working in the intrinsic and common pathway, and protamine sulfate is the reverse. Here is most important is the PCC, by the way. Prothrombin complex concentrate is the most, and the fresh frozen plasma. When you have a patient critical and you want to reverse warfarin toxicity, this will be the best. Vitamin K takes about 24 hours till start working. Okay, the next question.
75-year-old man is admitted for elective repair of an abdominal aortic aneurysm. Following the operation, his systolic blood pressure falls below 90, and during resuscitation, he's given an infusion of fluids. There is choice of colloid or crystalloid. Which of the following best describes why the intensive therapy unit registrar decides to administer a colloid?
Normally, in patient, shock the patient, and you give the patient history. You tell me a patient is shocking, even in some bleeding post-operative, sometimes angina, and patient has a postpartum hemorrhage or bleeding, any condition causing bleeding, and then you'll find that the emergency doctor tell you, okay, give IV history for this patient. Why especially history or this way?
So he wants to increase the circulating volume.
The patient, yes, he wants to expand the IV volume by colloid. Why he didn't give crystalloid, saline or dextrose or ringer?
Colloids is ringer and saline?
No, this is crystalloids.
Oh.
So yeah.
Colloids like Hystril or.
The question is asking which of the following.
Why the physician here or intensive registrar for ITU registrar decided to give colloid for this patient? This patient is shocking, is going in hypotension, and he has maybe abdominal aortic aneurysm, and he has a bleeding, post-operative bleeding.
It's very good.
And giving. Yeah. Why he preferred to give colloids, not crystalloids?
Yes.
Don't know.
From the age and the cause, the age 75 and the abdominal aortic aneurysm. So we need increase the volume, but not over giving a fluid. So it is more preferable to give colloid /
one of the causes, yeah.
Give him glucose?
No. We are talking colloids. Why? Okay.
مش colloids like الجلوكوز الدextrose.
Glucose ringers, all glucose and ringer and and saline or crystalloids. Colloids are heavy, like gelatinous material, or you can put in your mind like gelatinous material. Colloids are not freely permeable across the same permeable membrane. This is very common, by the way, and sometimes they use it in burn patient. In shocked patients, sometimes the patient loses the tone of the vessel and have a high vascular and high capillary permeability. If you give the patient, especially in old age, like Dr. Duffer said, if you give the patient normal saline or glucose or ringer solution, the patient has the possibility to expand the extra vascular volume as well. And the patient you can give him 6 or 7 liters of normal saline or ringer or dextrose, and the patient get edema and still the blood pressure low, because all the fluid can has a very easy permeability through the semi-permeable membrane or through the capillary permeability and through the vascular permeability, and can go for the extra vascular fluid volume and can increase the extra vascular fluid volume without actual increase or enough increase in the intravascular. What is colloid? Colloid will stay intravascular and it will not be permeable and will not go out the intravascular volume, and can elevate the pressure of the patient and can save the patient till the actual or the accurate intervention happen. Okay. Okay, next question. Clear about the last question?
Yes, sure. Clean.
35-year-old man develops septicemia following surgery for perforated acute appendicitis. He is hypotensive. Arterial blood gases analysis reveals the pH is 7.25, which is acidotic. The PO2 is 7.2, which is hypoxic. The PCO2 is 7.5, is hypercapnic. And bicarb is 17, which is low. What is most likely explanation for this reading? This is what we're talking about. Bicarb is low and carbon dioxide is high, and these are acidosis. So this is a mixed metabolic respiratory acidosis. Bicarb is low, mixed, yes. Where carbon dioxide is high, pH is low.
Perfect.
C.
Perfect, exactly. So this is acidotic, and then go for the CO2 and bicarb. If you find the CO2 is high, so this is respiratory. This is normal, so still respiratory. This is low, says it is mixed, or high also. Normal or high, it is also still respiratory. If you find bicarb low and CO2 normal, so this is metabolic, and so on. And this is how to solve a pH question in the exam. Put on your mind pH, CO2, and bicarbonate. Okay. Next question.
A 20-year-old man presents to the emergency department with a stab injury to the thenar eminence. On examination, he is found to have a 2 centimeter long laceration with loss of sensation in the thumb and index finger and weakness of the thenar muscles. Which of the following structure is most likely to have been injured? Thenar eminence is supplied by the median nerve. So this is also there is loss of sensation in thumb and index. So this is a sensory and motor branches of the median nerve. Because the recurrent branch of the median nerve is only sensory.
Exactly, perfect. So this is the way I am, perfect, Dr. Ahmed. This is the way I am thinking in the exam. I have here sensation and sinus, so I have a motor and sensory element. And for the median nerve, so I'll cancel the interosseous, radial and ulnar, all these cancel. So I have only these 2 choices. Here, he asking about the recurrent branch of median nerve, all sensory and motor. No, the sensory and motor branches are affected because they will affect the sensory and motor function of the nerve. Perfect, Dr. Ahmed. Perfect explanation. Next
you.
question. 2 questions, Dr. Ahmed, then go for anyone wants to share. Can also raise hand, or Dr. Dafer. Next 10 question will be Dr. Dafer. Okay. Dr. Ahmed, very easy question.
A 65-year-old man presents with vomiting and weight loss. On examination, he has 3 palpable epigastric mass. Transmedullary plane L1C. A 30-year.
Very fast question in the exam.
Yeah.
Very
A
fast
30-year
question. Okay, you are reading from your source, yeah? Go.
A 30-year-old motorcyclist is brought to the emergency department after a road traffic accident. He has an open fracture of the right femur. On arrival, he is tachypnic and confused with cold and clammy skin. Which of the following?
What this patient have?
Open fracture of the right femur. This hypovolemic shock.
Okay. What you expect the in the shock, the pH or the ABG of the
Metabolic
patient?
acidosis.
Metabolic acidosis. So what you expect in the parameters?
So look for the bicarb is low, decreased serum bicarb P.
Yes.
Decrease.
Okay.
Here B only.
This is fast. Yeah. Yes. Fast way to think. Here is, you don't know what will ask in the scenario. Go to the scenario. You will find decreased reabsorption of water, serum bicarb, increased pH of blood. Oh, so he is asking about the pathophysiology that will happen at the ABG or the fluid. The only accepted is increased pH. No, it is metabolic acidosis. It will have increased secretion of sodium in the urine. No, there will be preservation of sodium in the urine. In decreased reabsorption of water, there is increase in the reabsorption of water. There will be as water and sodium preservation to try to compensate and recover the patient shock. Increased sense of glycogen forever. No. In trauma patient, there is increase in glycogen lysis, and this destruction of the glycogen in the liver to give the patient glucose for power of the patient and for energy of the patient. So the most acceptable here is decrease the serum bicarb, because it means that is low pH or metabolic acidosis.
And also tachypnea, wash out carbon dioxide.
Tachypnea. Tachypnea, yes. Tachypnea to increase, compensate. Tachypnea to compensate the acidosis by decreasing CO2 level, and as we said, respiratory compensation is rapid within few minutes. Okay, thank you, Dr. Ahmed. Thank you. Dr. Dafer.
Okay.
Who's next after Dr. Dafer? Raise hand, please. Okay, Dr. Dafer, continue.
In an emergency situation, what is the most appropriate surgical method of obtain airway? Cut and retract the cricothyroid muscles, cut thyroid membrane, dividing the thyroid isthmus, enter the trachea at the level C7, or plies the cricothyroid membrane, E.
This is direct question 51 here, Dr. Rami. But in the exam, they sometimes put endotracheal tube, they put laryngeal tube. So what the way of answering this question?
Piercing the cricothyroid emergency, piercing the cricothyroid membrane. Don't say, not endotracheal intubation, nasal-oral or oral tube or oral laryngeal, all this, not just pierce the cricothyroid membrane is the only emergency. Otherwise, all are surgical interventions and not done except in hospital. Next question.
Okay. A 75-year-old man presented with hepatomegaly and ascites. CT show evidence of the post-hepatic portal hypertension. The inferior vena cava passes through the diaphragm At which level? T, 8, 9, 10, 11, 12. 8, number A.
Number A,
Yeah.
T8. Okay, this picture is very nice.
Can I add something, doctor?
Sorry?
Can I add something to this question?
Yes.
Yeah, I have made a mnemonic. It's Voice of America. So if you take Voice of America as
Yes.
voice is equal to vena cava 8, O for esophagus, or we called it as oesophagus, or E for esophagus, that is T10.
Yes. Yes.
And America is T12. So Voice of America.
Okay, it's very common mnemonic. Thank you. Really, right? Voice of America. Sometimes you have many mnemonic, by the way, like inferior vena cava. It is 8 letters. Inferior vena cava 8 letters, so it is T8. Esophagus is 10 letter. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it will go for 10, and aortic will be aorta will be T12. Okay. This is good. But I like always to know it by this picture, because aorta is the most posterior structure lying on the or beside the in the groove of the vertebral column. So it will start at T12, and the esophagus, it also comes posteriorly from the tendon in between the arcuate tendon of the diaphragm. It comes on the T10, and then the IVC, it go direct for the heart, because the heart is lying here, and you can find it here, so it comes at the level of T8. Okay, what is the most common structure passing with the aorta through its opening?
Thoracic duct.
Thoracic duct. Very important. Thoracic duct. And what is the structure coming with the esophagus through its vagi?
Vegas.
Anterior and posterior vagus. And what is the structure pass with the inferior vena cava?
Phrenic.
Right, phrenic. Very important coupling. Very important coupling. You have to know, by the way, in part A and part B. Structure passing with the aorta is the thoracic duct. Structure passing with the esophagus is the vagus. Sometimes here the sympathetic, tell you the sympathetic trunk, but keep this more, thoracic duct. And what is the with the cava is the right phrenic. And where is the left phrenic?
Surprise the left dome of the diaphragm.
Pierce the left dome of the diaphragm. Excellent, Dr. Doffer. Okay. Next question.
20-year-old woman presented acutely with abdominal pain. Image reveal a right ovarian cyst lesion, which excites. Histological examination shows cysts lying by the keratinized stratified squamous epithelial tissue. Area of fat, muscles, thyroid, neural tissue are seen in the wall. What is the most appropriate pathological design for this lesion? Adenocarcinoma, carcinoma, dysgerminoma, squamous cell carcinoma, and finally teratoma. So it's teratoma.
Exactly. So it is heterogeneous structures.
Yeah.
Heterogeneous structure like keratinized epithelium, fat, thyroid, and neural tissue. So all of these gives you a teratomatous structure. Next question.
25 years old woman who is 2 months postpartum presented with a tender mass in the left breast. She's pyroxial with raised white blood cells and raised seroactive protein level. A diagnosis lactation mastitis. What with abscess is made? Which of the following most likely causative organism? Orinomus haemophilus, E. coli, Streptococcus malaria, and Lactobacilli casei, and Staphylococcus aureus. Staphylococcus aureus.
Okay, Staph aureus is the most common organism in any abscess. Staph aureus is the most common organism and causing mastitis. As well as here is, if you can read, here is the causative organism Staph aureus and Streptococcus species, but the Staph aureus is the most common cause of any abscess in general. Next question.
62 years old alcoholic man is admitted with the severe acute pancreatitis. 3 days after admission, he's become hypoxia, PO2 is 7.5 kilopascal and confused. Chest X-ray show a uniform opacity of both lung field. Which one of the following most likely clinical diagnosis? A. Acute ventricular failure. B. Adult respiratory distress syndrome. C. Bilateral bronchial pneumonia. D. Bilateral labor pneumonia. E. Massive pulmonary embolism. So bilaterally acute pancreatitis goes with the adult respiratory distress syndrome.
Exactly. One of the most common complications and most common cause of death of patient of acute pancreatitis admitted to the ICU is ARDS, and the patient comes with bilateral uniform opacities. It will not happen with left ventricular failure or bronchopneumonia or lobar pneumonia or pulmonary embolism. It will not give this bilateral uniform patch opacities all over the lung, which will happen with the acute pancreatitis and sometimes other critical disease. Okay, next question.
58 years old woman presented to emergency department with a large fluctuator swallowing the site of the scent insect bite. She is anxious, tachycardia, and paraxial. On ECG show critical fibrillation. She is not to have a goiters. The swelling at the site of the bite requires surgical drainage. With the following classical of drug should be made appropriate a part of the preoperative preparation for surgery. Alpha 1 adenoreceptor agonist, alpha 2 adenoreceptor agonist, alpha adenoreceptor block, beta adenoreceptor agonist, and beta adrenoreceptor block. So it is E.
Okay. Beta blockers is one of the medication should be given to a patient with
thyroid disease.
Having thyroid disease before any operation. You have to control the patient sometimes with IV enteral, and very common patients with hyperthyroidism or any coming with any problem, and the patient is hyperthyroid, say coming to make hernia, coming to make cholecystectomy file and something like this. The patient have the anesthesia. Always recommend to give the patient IV enteral preoperative, just to avoid any complication of hyperthyroidism or parasite or thyroid storm or so. So they are giving beta blockers for this patient. Okay. Next question.
Nearly Paris, 30 years old woman, presented with the recurrent painful red area in the areola. She is give a history of the smoking cigarette. The lesion exercise at the histological show squamous metaplasia and lactiferous duct. Microbiological culture does not grow any organism. Which of the following is most likely diagnosed? Breast abscess, cigarette, carcinoma of the breast, fibroadenoma, galactoria, subareolar abscess. So it is subareolar abscess.
Okay. When you find this scenario, young patient, heavy smoker, and actually, if he did give you the microbiological culture or not, you will go direct for important thing. What's called duct ectasia?
Yes.
Duct ectasia. Plasma cell mastitis. Or sometimes here he changes the mnemonic for subaerial abscess. Subaerial abscess. All these the same, but this is the most common things we know. Duct ectasia or plasma cell mastitis, and this is the common scenario. Cigarette smoking and nalipara. So you go for this. If you didn't find this, you go for this. If you didn't find this, you go for this, because this is duct ectasia is dilatation in the subaerial terminal ducts. Okay, subaerial terminal ducts, and actually the histopathology will show you plasma cell or sometimes lymphocytic infiltration. Lymphocytic infiltration. That's why we called it plasma cell mastitis. If you don't find, so it is will be the will have what's called subaerial or periaerial abscess. Next question.
65 years old man undergo right hemicolectomy on the second post-operative day. He is afebrile, nauseous, and have distended abdomen, but very little pain. He is on the intravenous morphine via patient control analgesia pump. Patient X-ray confirm distended loop of small intestine. The physiological base of the post-paralytic ileus involve stimulation of the dopamine receptor, stimulation of the reverse migrating motor complex, stimulation of the MEM receptor, suppression of the muscarinic receptor, suppression of the motilin due to the starvation. So it is C.
Very common when he asks you about any question about morphine in the exam, he wants to ask about the receptor. Questions come about morphine in the exam. Ask about the receptor or ask you about the side effect of morphine, which is the respiratory depression or sometimes the paralytic ileus. But in the paralytic ileus question, he asks you about the receptor. You want to know the receptor. Or give a scenario that gives the patient has a respiratory failure type 1 or acute respiratory failure, or the patient has respiratory depression. And this will be one of the morphine side effects. This is by the way, most questions about morphine you will face in the exam. Okay, you can read here, morphine side effect is respiratory depression or constipation due to paralytic ileus, nausea and vomiting. Most patient you'll face in your field who talk intraoperative morphia. Post-operative, you'll find the patient tell you, I maybe till the end of the day, for one day, I'm feeling nauseous and he want to vomit, because a very common side effect of morphine and sometimes pethidine, that the patient feel like he is nauseous all the time. Next question.
42 years old woman has cholecystectomy, develop of self-limit post-operative wound infection. But what process which bacteria ingestion have been enhanced? Apoptosis, autophagus, foci, metaplasia, opsonizing on the phagocytosis. It's D.
Opsonization. Yes, exactly. Opsonization. This is a process by which macrophage or post-operative and made by macrophage ingestion of bacteria. Bacteria is ingested by the process of opsonization. Next question, please.
60 years old, non-smoking, presented with 3-month history of loose weight, malaise, and breathlessness. On examination, he has left supraclavicular lymph node enlargement. Chest radiograph reveal multiple bilateral opacity. What is abnormality would a biopsy of the left supraclavicular lymph node must probably show. Chronic inflammatory cells, granuloma, Langerhans type giant cell, multiple abnormal mitotic figures in the cell, red Sternberg cells. So it is D, multiple abnormal mitotic figure in the cell.
Why?
أولاً, from the age 60, weight loss, malaise, and breathlessness is for chronic something chronic lymph node enlargement. So it is either the TB or the malignancy.
This is the age of TB.
No.
Mostly will give you. So
yes,
this is the clue. This is the clue of this. This patient and left supraclap. So this is vertical lymph node. So this patient, he wants you to know this patient is having a malignancy, loss of weight, malaise. This is, by the way, cardinal symptoms of malignancy you have to ask about in history stations in part B. Ask the patient, do you have any body swelling, especially neck swelling? Do you have unintentional loss of weight? Do you have weakness or loss of appetite? This is very common question. If the patient gives this question positive in the exam, in the history or communication station, your first provisional diagnosis should be malignancy. You have to make this in order. The doctor will ask you, doctor, okay, after you finish your history, what's your provisional diagnosis? You have to tell him, I doubt malignancy, or I doubt cancer, and then I can go for chronic TB or any other cause. So this is neoplasia, and this is the cardinal features of neoplasia that the patient has, that the cells have multiple abnormal mitotic figures. Multiple abnormal mitotic figures. Chronic inflammatory cells, no. Granuloma, this is a chronic inflammation. Langerhans giant cells, the same as happens with TB. Red Sternberg cells with Hodgkin lymphoma. Okay, but multiple abnormal mitotic figures is only with cancer cells. Okay, who's next? Dr. Giga, open your mic, please. Hello.
Hello.
Yes,
Hello.
doctor.
دكتور رامي
دكتور.
حضرتك دكتور رامي
تمام.
محمد ليك يا فندم 75 78
اهلا وسهلا بك. اتفضل يا دكتور. دكتور محمد.
ايوه يا فندم 78 years old woman with emphysema receiving 28% oxygen by mask and has the following blood gas results: pH acidotic, BCO2 hypoxic, BCO2 acidotic, bicarb alkalosis, base +5, mixed respiratory and metabolic acidosis, partially compensated metabolic acidosis.
What do you expect without reading the answers?
Partially
without reading the choice. Give me a comment.
Partially compensated.
Give me a comment here. This is acidosis.
Partially compensated respiratory acidosis. As
this is uncompensated. Or partially compensated.
Partially compensated. pH acidotic, الBCO2 الBCO2 acidosis, البيكارب alkalosis. Partially compensated
because the bicarb is high.
Yes.
Because the bicarb is high, and we have
BCO2.
here acidosis.
Yes.
Yeah.
Yes.
So partially compensated respiratory acidosis. Sometimes here give you another choice, which is right.
Uncompensated respiratory acidosis.
What? Yes. If he didn't give you respiratory acidosis, what is the mnemonic that can give you then respiratory acidosis?
Respiratory failure.
Respiratory failure. Very common, by the way. If you search in the answers about respiratory failure, if you search about respiratory acidosis and you don't find, respiratory acidosis has another mnemonic, which is respiratory failure, which is type 1 and type 2. What is this type?
PO2 type 2, hypoxic.
Hypoxic and hypercapnic.
And hypercapnic.
And hypercapnic, so this is type 2. Type 2 respiratory failure, and then you will find many questions in the exam. You just find this ABG, okay, this is a respiratory acidosis, compensated or not compensated, then go to the question, you don't find any answer, so you get confused. No, respiratory failure equals respiratory acidosis. Okay.
Yes, okay. A 2 years old child is referred because of impalpable testis in the left scrotum. Which of the following position describe an ectopic test? At the deep inguinal ring, at the root of the penis, at superficial inguinal ring, inguinal canal, in the upper part of the scrotum. At the root of the penis. B.
At the root of the penis.
Yes.
It is not on the normal pathway of the testis. The
Yes.
normal pathway of the testis is intra-abdominal, or at the internal ring, or through the canal, or at the external ring. Okay, but at the root of the penis is completely root of the penis, or perineum, or in the femoral triangle, or in the outside the canal. This is all ectopic testis. This is all ectopic testis. Next question.
60 years old man is found to have 2 cm diameter mass in the upper lobe of his lung. The region excised, and it's found that the lesion includes connective tissue, matter, cartilage, and ciliated epithelium. What is the most likely diagnosis? Adenoma, carcinoma, chondroma, hamartoma, sarcoma. Hamartoma.
The same like teratoma. Hamartoma, it is mixed tissue.
Connective tissue.
Mixed connective tissue. Mixed connective tissue, different from different tissue. So this patient having a teratoma. Hamartoma.
Yes.
Hamartoma. Exactly. Next question.
A 23 years old man presents 3 months following extraction of carious teeth with plaque-like infiltration over upper jaw, with sinus formation, yellow granules, and present in the discharging pus. What is the most likely causative organism? Actinomycosis, Aspergillus, Blastomites, Cryptococcus, Histoplasma. Actinomycosis. Yellow, sulfur granules, discharging. Actinomycosis. Type A.
Actinomycosis. Okay.
Yellow granules.
So yellowish granules. Yellowish granules, or sometimes tell you, sorry, or sometimes tell you silver granules or sulfur granules. All this a picture of
Actinomycosis.
Actinomycosis. Yellowish granules. Okay, next question.
82 years old man has complete occlusion of his inferior mesenteric artery on angiography, but no symptom signs of colonic ischemia. Which of the following arteries is the most likely the additional source of blood supply to the arteries of the inferior mesenteric artery? Left colic, left gastroepiploic, medial colic, splenic, superior rectal. Middle colic. Middle colic. C.
Middle
Colic.
Colic. Okay. So here, inferior mesenteric artery on angiograph has no symptom or sign of chronic ischemia. Complete occlusion. Which of the following arteries will give you an additional forced blood supply to the infers? Very common question, by the way. Very common question, by the way. He tell you sometimes occlusion of the inferior mesenteric artery. Sometimes the patient went for sigmoidectomy or left hemicolectomy. Then what will provide the blood supply to the rest of the left colon? Keep in mind that the middle colic have an extension blood supply to the left colic, and that's why give a good blood supply. And we have to confirm this during a colectomy or during sigmoidectomy, because we will depend on the left colic artery, or sorry, the middle colic in giving supply to the rest of the left colon. Next question.
An intravenous drug abuser is having an echocardiography for suspected endocarditis. Closure of the tricuspid valve occurs at the onset of which phase of cardiac phase or cardiac cycle: arterial systole, isovolumetric contraction, isovolumetric relaxation, rapid ejection, rapid ventricular filling. Closure, isovolumetric contraction. B.
Exactly.
Closure,
Isovolumetric
contraction.
closure. C. With C, isovolumetric contraction. Very important, very important, very important. This picture and this diagram to know. Most important is a wave, which is responsible or presenting the atrial contraction, and it is lost in AF, and it is giant in what is called cannon wave A, and also very common in the exam, the C wave, which is closure of the tricuspid valve, which happened on the isovolumetric contraction. Isovolumetric contraction. Wave V, filling of the atrium. Venous filling or filling of the atrium is a V wave. But this is the most common, by the way. This is the most important repeated in the exams. Okay, so our answer here is isovolumetric contraction. Okay, next question.
After being stabbed in the left groin, previously healthy 20-year-old man was admitted to the emergency department. He developed hemorrhagic shock during resuscitation. 10 units of type O negative red cells and 6 liters of colloid were administered. 24 hours later, he noted to have severe dyspnea, for which he required intubation and ventilation on the intensive care unit. Which of the following would be the most likely cause of his respiratory insufficiency? EBO, blood incompatibility, adult respiratory distress syndrome, congestive cardiac failure, tension pneumothorax, viral pneumonitis. Adult respiratory distress syndrome. B.
Adult respiratory distress syndrome. Patient admitted to the ICU with
stabbed in left groin.
Especially this patient who receive massive blood transfusion, which is almost replacement of the whole blood, massive blood transfusion, replacement of the whole blood volume within less than 24 hours. This patient is very susceptible for adult respiratory distress syndrome. This patient go for ARDS, and I know many patients personally who get this problem. The patient may have, it's okay, good blood pressure and everything, but the patient go for adult respiratory distress syndrome, or sometimes what's called sometimes associated transfusion associated lung injury, which is adult respiratory distress syndrome that happens with the massive blood transfusion. Massive blood transfusion. Okay. Next question.
80-year-old man with a history of hypertension controlled with diuretic. Undergo urethral resection of the prostate under general anesthesia. The surgery is prolonged, and in the recovery room, he complains of nausea and headache. He later became agitated and confused. Which of the following is the most likely diagnosis? Hypercalcemia, hyperuricemia, hypoglycemia, hypokalemia, hyponatremia. Hyponatremia is the most common post-TERB syndrome. Hyponatremia.
Post-URP syndrome is a very common question and very common station in part B. Patient have post-URP, the patient suffers from agitation, confusion, nausea and headache and vomiting. This is because of hyponatremia. So I think you know the mechanism of hyponatremia. Why happened hyponatremia in this way? You can read the first picture. Can you read this, please?
Yes. Rapid absorption of large volume of irrigation solution.
Okay, irrigation solution. This is a hypotonic solution, and in rapid irrigation, the dilated veins of the prostate will have an absorption of large volume, will give the patient will suffer from hypervolemia, hyponatremia, and hypernatremia. This patient will get agitated and confused because of brain edema. And this patient will have difficult respiration because of lung edema. This patient will go for many complications, but more in details in part B. You have a very big station about a TURP patient that and he will ask you about the mechanism of hyponatremia, and he will ask you about the mechanism of confusion on this patient, and he will ask you about the mechanism of the patient difficult breathing and hypoxia because the patient will go for lung edema. Okay, and he will ask you what is the solution now. They are using why they are using the irrigation solution hypotonic, Dr. Ahmad Az. Why they are using the hypotonic solution in this patient?
For continuous irrigation.
Because we use electrocauterization, and electrocauterization will not act in normal saline. We need water.
Exactly, because now the new instruments they use, they can use normal saline or saline solutions.
Bipolar devices.
And bipolar device, exactly. First, they are using unipolar, and they can't use the irrigation solution, and now they are using the bipolar, and so they can act with normal sodium or containing solutions other than the hypotonic glycines used before. Okay, continue.
35
so this is
years old.
Hyponatremia. Okay.
35 years old man admitted in the hospital with vomiting, nausea, and severe headache. An MRI scan reveals a tumor of the cerebellopontine angle. Which of the following pairs of cranial nerves is most likely to be compressed? Accessory and vagus, facial and vagus, facial and vestibulocochlear, glossopharyngeal and vestibulocochlear, vagus and vestibulocochlear, facial and vestibulocochlear. C.
Exactly. Very common question in the exam.
Cerebellopontine.
Cerebellopontine angle 7 and 8. Cerebellopontine angle 7 and 8. I want you to always remember this mnemonic about the cranial nerve origin: 2, 2, 4, 4. Okay, 2, 2, 4, 4 from the cerebellar hemisphere. The first 2 from the
midbrain.
1 and 2 from the midbrain comes 3 and 4. From the bones come 5, 6, 7, 8. In the angle 7, 8, and then the medulla, the last 4 cranial nerve. 2, 2, 4, 4, like a football match. You have to remember the cranial nerves: cerebral, midbrain, bones, and medulla. In between this 7 and 8 will be in the cerebellopontine, by the way, cerebellopontine angle. Here, cerebellopontine angle will be the 7 and 8. So very common question in the exam, almost repeated every exam.
Dr. Rami, can I ask a question?
Yeah, تفضل.
In MRCS, there's a question, the same tumor at cerebellopontine angle, but he mentioned the trigeminal nerve to be the most as it has a wide base. The explanation is that it has a wide base and it is more likely to be injured. A question like that, and the facial nerve, I think, was mentioned in the options. A trigeminal and the explanation.
Here is where is the trigeminal? Here is not here. The trigeminal, by the way, okay. The trigeminal comes from the, also, by the way, the trigeminal is also in the cerebellopontine angle, by the way, if you like. If cerebropontine angle, not cerebellopontine angle, cerebropontine angle. I want you to share the question, but I can remember this question, but it wasn't cerebellopontine. I think it was cerebropontine angle.
Okay, if I found it, I will share it in the Telegram group.
Okay. Share in the group and we can discuss what is the difference. Sometimes he can give you some manifestation about trigeminal neuralgia. So you have to go for trigeminal.
It's MRCS question about the trigeminal nerve because it has wide trunk. So it's easy to be compressed with tumors.
Okay, but sometimes it gives. Okay. Yani share this, but this is the most common cerebellopontine. If cerebellopontine, 7 and 8, that's very common questions in the exam, and this is the ideal answer for it. We need the complete scenario of the trigeminal so we can make the difference and know the difference between both of them. But in exams and recalls and in the exam, you'll find this question.
Okay.
Okay, next question and last question, Dr. Muhammad.
After resection
of Dr. Mu'tasim. Okay.
Yes. After resection of rectal tumor, a patient experiences erectile dysfunction. Which of the following nerves is most likely have been damaged? Genitofemoral, lumbosacral, pelvic splanchnic nerve, perineal branches, phase 4, pudendal nerve, pelvic splanchnic nerve. C.
Okay, pelvic splanchnic nerve is responsible for innervation and erectile dysfunction. Sometimes he tell you the inferior hypogastric plexus, and very common in the exam. After rectal tumor or after prostatectomy, the patient has erectile dysfunction. Most commonly inferior, or sometimes he don't mention inferior, he tell you hypogastric plexus بدون الدخول في التفاصيل of hypogastric plexus بيتكون من ايه. Okay, the patient, or sometimes pelvic splanchnic plexus. All these will be responsible for the erectile dysfunction post cancer, rectum cancer, or sometimes the prostatic cancer.
Dr. Rami.
Thank you, Dr.
Yes.
Rami.
I found the question and I sent it in Telegram group with the explanation.
Okay, minute, please.
You will find it in the group.
Forcibly developed a cerebellopontine angle lesion. Which of the nerves listed below is likely to be affected first? And then he mentioned 10, 3, 5, 9. He didn't mention 7 and 8.
He mentioned
5.
Only 5 mentioned.
Trigeminal.
Show If he mentioned 7 or 5 or 8, all
Okay.
these maybe he didn't mention here 7 or 8. Very nice question, Dr. Mu'tasim. Thank you. Thank you. So if he didn't mention facial and
vestibulocochlear.
the vestibulocochlear, you can go for fifths. So we have the fifths, 7th, and 8th all in the cerebral. But I think here, make sure that not MRCS has many mistakes many times, by the way. And if you give a feedback for them, they can sometimes the correct answer. I think it is not cerebellopontine, it is cerebropontine.
Okay.
So MRCS يعني they are برضه مجتهدين زينا برضه زي ان هم يجيبوا الكويستشنز ويعملوا كده. By the way, past test is هو المعتمد اكتر من الرويال كوليج ان هو يدي اسئله recalls or near questions, but not the MRCS. Okay, thank you, Dr. Mu'tasim. So can you start the next 10 questions, please?
Thank you, Dr. Rami.
Okay, welcome.
Okay.
Thank you, Dr. Muhammad.
Thank you, Dr. Rami.
A 45-year-old woman presents with pain, swelling, and stiffness.
Sorry, Dr. Mu'tasim. Sorry.
Okay.
Yes, okay.
A 45-year-old woman presents with pain, swelling, and stiffness affecting all her metacarpophalangeal joints. She has noticed weakness in her grip and her handwriting, and her handwriting has changed. She is unable to extend her fingers fully. The index, middle, and ring fingers in both hands show an ulnar deviation. The most likely diagnosis is tubular contracture, gouty arthritis, osteoarthritis, radial nerve palsy, rheumatoid arthritis. The answer is E, rheumatoid arthritis.
Exactly. He didn't give you enough data, by the way, in the question about why you go for rheumatoid, why you don't go for any other question. But ulnar deviation in these 3 fingers, ulnar deviation is characteristic for rheumatoid arthritis, not characteristic for Dupuytren's contraction, not or any type of infection or inflammation like arthritis or osteoarthritis or even radial nerve palsy. But it is characterized to rheumatoid arthritis. Ulnar deviation is, by the way, this question is very common as well. I think it came to me in April 2019. Okay, next question.
A 22-year-old man arrives to the emergency department with sudden breathlessness due to a large pneumothorax. A chest drain is inserted into the 5th left intercostal space in 5th mid-axillary line. There is hemorrhage into the drainage bottle. Which of the following structures is the most likely cause of this acute hemorrhage? Intercostal artery, left pericardiophrenic artery, lingula of the lung, right ventricle of the heart, spleen. Intercostal artery. Intercostal artery. A. Yes. Number A.
This question is very nice question. I like it in anatomy. By the way, you have about 70 to 80 questions of anatomy in the exam. So most anatomy question you'll find in the exam. This question is coming every exam. The most common injury is the intercostal artery because you have the vein, the nerve, artery, and vein is almost covered by the in the groove of the rib. So in any bleeding, you will find up and down the artery. So intercostal artery is the most common site of bleeding in any chest tube. Okay, next question.
A 65-year-old woman collapses after a total hip replacement. A pulmonary embolism is suspected. Which of the following electrocardiogram changes would suspect this diagnosis? Dominant R wave in V6, left axis deviation, left bundle branch block, ST elevation in V1 to V3, T wave inversion in V1 to V3. Pulmonary embolism. I don't know. Swank Q3 T3.
Don't forget this in the exam, and you'll find it in the exam. You have a question about pulmonary embolism, ABG in exam in part A and part B. You will be asked S1, Q3, T3. Okay,
تمام.
very important. S wave in lead 1, Q wave in lead 3, and inverted T wave in lead 3 as well. Sometimes he adds here V1 to V3. So T wave inversion is the only one here. No ST elevation, you'll find it in ischemia. Left bundle branch block, no. Left axis deviation, you'll find it in hypertrophy. Dominant R wave, I don't know exactly, I'm not expert in ECG, but inverted T wave is very common with pulmonary embolism. So the answer will be
E, T wave inversion in V1 to V3.
T wave inversion in V. This is very characteristic for
pulmonary embolism.
Pulmonary embolism ECG. Don't forget S wave in lead 1, Q wave in lead 3, and also inverted T wave in lead 3. And it will come in the exam like this, by the way. S1, Q3, Q3, and it gives you the details like this.
Okay.
Here is also, you'll find inversion of T wave from V1 to V4.
Okay.
Next question.
A 40-year-old woman had an anterior lobe of the pituitary removed because of a tumor. Without postoperative supplements, which of the following could occur? Failure.
This direct question about the hormones
released from
released by the anterior and posterior pituitary.
Failure to produce adequate amount of thyroxine. Okay.
Right or wrong?
That is wrong. That's right because of cytotropin releasing. Okay. So, that's right.
If you find in the exam, if you find the answer and you are make sure 100%, just go with your eyes direct to the other. Very easy. Just know that the posterior pituitary have the
oxytocin.
Yeah, oxytocin and antidiuretic hormone. Others are anterior pituitary. Yani, just to remember, by exclusion, if you can't remind, and the exam will be under tension, and just know the oxytocin for milk and antidiuretic hormone for what happened with accident or any hypovolemia or something like this is from the posterior pituitary. Other things, thyroid, ACTH, prolactin, growth hormone, FSH, LH, all others from anterior pituitary. Next question.
A 38-year-old man in end-stage renal failure resulting from polycystic kidney disease receives a cadaveric renal transplant. Good renal function is established, but 4 weeks later deteriorates. The serum creatinine rising by 25%, 25%. Which of the following processes is most likely to be responsible for this deterioration? B cell-mediated rejection, circulating immune complex disease, IgG antibody-mediated rejection, post-transplant lymphoproliferative disorder, T cell-mediated rejection. The rejection occurred 4 weeks later, so it can be considered acute rejection.
Okay.
And most probably due to the answer, I think the table below. Cell-mediated, T cell-mediated rejection, T cell-mediated immune response.
Okay. In hyperacute, that happens the patient on table or just in the few hours, okay, or in the first few days, it is antigen-antibody reaction. Antigen-antibody reaction, most commonly ABO or HALA-DR. Okay, or ABO. This is the most important. This is the most important antigen that I code. If they are not competent, the patient will have hyperacute. Okay. If we went for acute, which happens in weeks, 2 months, it will be T cell mediated. T cell mediated. Okay.
Okay.
This is the most important too. After few years, it will be some sort of chronic process. It is also T cell mediated, but there will be fibrosis and atrophy of the kidney. This will be chronic, and this happens after many years. Okay, about low grade immunity or low grade rejection of the process of rejection of the transplant. But more important, the first two. First one, ABO or HALA-DR incompatibility, which is antigen antibody reaction. The acute within weeks to months, it will be T cell mediated. So answer would be
T cell mediated rejection.
T cell mediated rejection. Next question.
In order to expose the right axillary artery, a transverse skin incision is typically made below the clavicle from a point just lateral to the sternal end of the clavicle to the deltopectoral groove. Which of the following structures would be encountered in the dissection down to the vessel? Lateral thoracic artery, phrenic nerve, suprascapular artery, thoracic duct, thoracoacromial artery.
What do you expect?
I can exclude, but I can exclude the phrenic nerve. I can exclude.
This is anatomy. This is anatomy. And this question is repeated every exam, even in last exam. Most exam, two of the three exams per year, this is repeated question.
It will be, I think, thoracoacromial, according to the diagram. Thoracoacromial?
Exactly. Thoracoacromial artery. Many pictures, by the way, many pictures. Even I have a very nice picture I saw a few days ago. Deltopectoral groove. Thoracoacromial is thoracoacromial artery is very common to be injured together with the cephalic vein, by the way. But he doesn't bring always the cephalic vein is more deep. But any incision in the thoracoacromial groove, or sorry, the deltopectoral groove, you can injure the thoracoacromial artery or sometimes acromiothoracic artery. By the way, in last exam it gives acromiothoracic artery or the cephalic vein sometimes. But he doesn't give cephalic vein didn't come before. Didn't come before. Okay. Next question.
A 4-year-old boy presents to the emergency department with a 2-day history of headache, vomiting, and drowsiness. A CT scan reveals dilatation of both his lateral ventricles and his third cerebral ventricle. His fourth ventricle was of normal size. It is suspected that he has an obstruction to his cerebrospinal fluid flow. At which of the following sites is the obstruction most likely to be? Cerebral aqueduct of Sylvius, infundibular recess, interventricular foramen of Monroe, lateral foramen of fourth ventricle, median foramen of fourth ventricle. Because of the dilatation of the lateral ventricles and the third ventricle, the fourth ventricle is normal. So the problem is in aqueduct of Sylvius, which connects
aqueduct of Sylvius. Okay. Exactly. Aqueduct of Sylvius is the most common. And by the way, in the exam, they only like this aqueduct of Sylvius. Only like this. They repeat it in the exam by different scenario of cerebral interventricular hemorrhage, hydrocephalus, and give you this scenario the same. And he liked to know that this is the most common site of obstruction in the cerebrospinal fluid is the aqueduct of St. Okay, next question.
A 12-year-old boy presents to the emergency department 2 hours after helping his father cut the grass. He complains of rhinorrhea, itchy eyes, sneezing, and blocked nose. He is apyrexial with hemoglobin of 12 and white blood cell count of 6.8 with a raised eosinophil count. Chest X-ray is clear. Which immunoglobulin is most likely to cause this reaction? A, D, E, G, M. I think it's immunoglobulin E, which is responsible for anaphylaxis.
Exactly. As we said, acid AGT. Acid E G G T. Okay. Anaphylactic or immediate will be IgE. Cytotoxic will be G. Immune complex will be G. Then delayed will be T. This is very important mnemonic in the exam. Okay, so this is anaphylaxis, immediate. So it will be IgE, then IgG for antibody mediated or cytotoxic. Immune complex will be also IgG, and then T cell will be with the delayed. Okay.
Okay.
Next question.
35-year-old woman undergoes a gastric bypass surgery for morbid obesity. At a subsequent surgical clinic review, she complains of dizziness, sweating, palpitation, and collapsing episodes after big meals without any vomiting or pain. She is otherwise well and has no medical problem. What is the most likely explanation for her symptoms? It's the dumping syndrome. It's due to insulin release uh, post post meals. The release of insulin. It's due to release of insulin, which causes hypoglycemia.
It is a early or delayed dumping?
It is delayed dumping syndrome.
Delayed dumping. Do you want why is early dumping happens?
Early due to high osmolarity of food bolus, which cause
Yes.
the absorption of fluid from body to intraintestinal lumen, which cause hypotension.
Okay. Can you read this table fast, please? Dumping syndrome.
Okay, dumping syndrome. It occurs in gastrectomized patients. Rapid and unregulated dumping of the chyme into intestine. It's two types. Attacks last about 30 minutes. The early type, the early dumping syndrome, occurs immediately after a meal. It is associated with hypovolemia and hypotension. Caused by hyperosmotic chyme entering duodenum, which rapidly extracts large amount of fluid from circulation into intestine. The other type, late dumping syndrome, occurs approximately 2 hours after a meal. It is due to hypoglycemia. Chyme dumped into intestine results in rapid absorption of glucose into blood. So sudden blood hyperglycemia leads to rapid increase in insulin that overcorrects and results in hypoglycemia. Symptoms of late dumping syndrome includes weakness, dizziness, and sweating after meals.
Exactly. So this is late dumping due to insulin and hypoglycemia. Insulin release and hypoglycemia. Next question. Very common question in the exam.
Okay. A 65-year-old man with chronic emphysema is on the high dependency unit 10 days after anterior resection. He has developed acute shortness of breath and hypotension. Which of the following landmarks would be most appropriate to use to obtain a femoral arterial blood gas sample? A point midway between anterior superior iliac spine and the pubic tubercle, a point midway between the anterior superior iliac spine and the pubic symphysis, a point midway between the greater trochanter and the symphysis pubis, a point 1 centimeter inferior and 4 centimeter lateral to the pubic tubercle, a point 2 centimeter lateral to the midway point between anterior superior iliac spine and symphysis pubis. I wanted to take blood gas from femoral artery, so I will go to mid-inguinal point. Mid-inguinal point, midway between anterior superior iliac spine and symphysis pubis. So it is point midway between, it will be B. The answer is B, midway between anterior superior iliac spine and symphysis pubis.
Okay. Very common, and sometimes having confusion in this question, confusing question. Don't be confused. I always say in simply, I can go the ligament and the ring. The ligament and the internal ring and the external ring are one family together. So if you want to ask about the external ring or the internal ring, you have to relate it to the ligament. So where is the external ring? It is the medial side of the ligament. Where is the end side of the ligament? Where is the internal ring? It is on the middle of the ligament. Middle of the ligament. Okay. But inguinal area is not related to them. Inguinal area is responsible for the artery, for the femoral artery. So if he told me mid-inguinal, I go for the artery. If he told me mid-inguinal ligament or midpoint of inguinal ligament, as he mentioned the ligament, I'll go for his two siblings, which is the internal and external ring, and almost asking about the ring. Clear? So here's the ligament. I go for the ring. But if he just said midpoint and he didn't mention the ligament, so he asking about the mid-inguinal point in general, we can go for the femoral artery. Next question.
I think I next.
Okay, who's next? Who can go next, please? Who didn't share can share with us today. Dr. Muhammad, Dr. Mustafa, Dr. Noha, Dr. Iman, Dr. Ahmed Al-Morsi, Dr. Muhammad. Okay, open your mic.
Okay.
Okay, Dr. Muhammad, you can ask. You can go for the next question.
Yeah, a 70-year-old man complained of persistent numbness since as inguinal hernia repair 1 year previously. The numbness affects the top of the scrotum, root of penis, and a small area below the medial part of inguinal ligament. Which nerve is likely to have been damaged? So this guy, he underwent inguinal hernia repair, and now he presented with numbness affecting top of scrotum, root of penis, and a small area below the medial part of inguinal ligament. I will go with the genital branch of the genitofemoral nerve.
Why?
Sorry.
Root of penis. Root of penis.
Yeah, sorry. I will go with the ilioinguinal nerve.
Exactly. Very common in the exam. By the way, they rarely they get the genital branch of the genital femur nerve. He is asking almost about, or the femoral branch. Always these two. He likes to ask about the chromostatic reflex. Okay, these two almost in the exam in the MRCS, when he asks about the chromostatic reflex and ask which is responsible for them, go for this. Femoral branch is the afferent and genital branch is the efferent. Okay, most common nerve you injure during hernia operation and make number, especially he told you root of penis and top root of penis and the top of the scrotum and part of the inguinal area. This is the ilioinguinal nerve, very common. Go direct for this. Inguinal hernia repair, most common nerve injury is the inguinal nerve. They will not misuse you. They will not give you mystery or ask you about question that's not clear. No, ilioinguinal nerve is the most common, and that's the patient-wise. Sometimes after many months or sometimes years, the patient come with paralytic direct inguinal hernia, because paralytic direct inguinal hernia happens here due to weakness in the inguinal area from injury of the ilioinguinal nerve, and also happens with appendectomy. Sometimes happens with appendectomy. Okay, when we make lance incision or we make extension in subhepatic appendix, we injury of the ilioinguinal nerve happen. Okay, next question.
Okay, a 12-year-old girl has a diastolic murmur. It's maximally audible in the second left intercostal space, pathology of which structure is the most likely cause. So a girl with a diastolic murmur in this left second, which will be the pulmonary valve.
Exactly. Simply mitral.
Pulmonary valve.
Second, who said mitral valve?
One.
Who? You?
No. No one said.
Okay, so the second left pulmonary, you will feel most common you will have a diastolic murmur, diastolic regurg murmur. In aortic area on the second right, he will tell you ejection systolic murmur most common. Ejection systolic murmur. In the fifth left intercostal space, and this is also very common, mitral valve. If he told you mostly will give you a diastolic, mid-diastolic murmur, and this will happen with the mitral regurg. Okay, so in aortic, he will tell you ejection systolic murmur. Okay, if you can't remember ejection systolic and diastolic, and this is go for the area direct. Go direct for the area. On the left side, second pulmonary, on the right side, aortic, on the fifth intercostal space, on the mid-clavicular line, it will be a mitral artery, except he will give you a mitral regurg or mitral stenosis. The stenosis will give me a systolic murmur, regurg will give you a diastolic murmur. Clear?
Yes.
Okay. Next question. Very common question in the exam.
A 34-year-old pregnant woman develops a swollen leg. Her mother and maternal aunt also had similar problem during their pregnancies. Which of the following tests?
What do you expect the problem here to be?
I think this lady, she presented with a DVT with
family history of DVT.
Yeah, family history of DVT. Similar problem in their pregnancies. I will go with antiphospholipid syndrome.
Antiphospholipid or anticardiolipin syndrome is the only congenital or the most common congenital cause of inherited DVT is antiphospholipid or anticardiolipin, sometimes antiphospholipid, sometimes anticardiolipin, anticardiolipid antibody syndrome. Both of them are responsible for the hereditary or familial history of recurrent DVT.
معلش يا دكتور رامي، مش دكتور نسا، بس انا بسمع دايما ان كل السادة الحوامل بيبقى رجلهم متنفخه يعني in English يعني
بس مش DVT لا مش DVT، حرام عليك، مش
DVT.
DVT.
question here there's DVT. لا يعني where is DVT in the question here?
What is the DVT question here?
Yeah.
Family history.
Swollen leg.
I'm telling that
and maternal heart also had similar. No, not swollen leg here mean يعني في difference between edema of pregnancy or ankle edema of pregnancy that happened at the end of this is ankle edema happened at the end of pregnancy and maybe in the last 2-3 weeks or in the end of third trimester away from swollen leg. Swollen leg
يعني usually say swollen leg, tender cuff, painful cuff, redness.
But if he didn't give you هنا يعني okay, what will you expect here to give you? Here is okay, by from the answers he wants you to think about DVT.
Yeah, but I don't know any single of the answers. يعني if I don't know only antiphospholipid, but I cannot confirm that is the answer.
So
okay, just know this question it come with the same question and same choices almost every years or every 2 exams every year. 2 exams per year. This question come with that. Sometimes give antiphospholipid, sometimes anticardiolipin. Okay, sometimes antiphospholipid and sometimes anticardiolipin. Both of them antiphospholipid or anticardiolipin. Sometimes lupus anticoagulant, but this is the most common. Antiphospholipid and recurrent. He tell you the patient and her mother and her aunt and all the family have this problem. So this is the only hereditary and congenital or inherited complication of deep venous thrombosis. Really, some question, if you can't remember, you can't understand, know the question. In the exam, you'll find this, you go direct for. It came for me in April 2019. I can remember this question. I wasn't understanding it, but I read it many times. When I came in the exam, I did choose direct at all. Pregnant woman, swollen leg, her mother. I left the question and go direct for the answers, and I find anticardiolipin, and I did choose anticardiolipin. Some questions in the exam you'll do it by يعني بالبركة كده زي ما يقولوا. إن شاء الله. Okay.
Okay.
Next question.
The fight or flight response produces a release of epinephrine. What is the primary metabolic effect of epinephrine? So right now we are facing a sympathetic response and we need to know what is the primary metabolic. For metabolic, I will go with glycolysis.
Okay. This question is was one of the confusing questions for more than 2 years. And most recall some answering it tachycardia and some answering it glycolysis. Okay.
Yeah, but
and some they said no primary metabolic effect. He don't need metabolic. He said that the metabolic effect of epinephrine, what will cause? Okay, metabolic effect of epinephrine will cause tachycardia. Okay, but he don't know. He don't need the metabolic effect. However, this photo, it takes me about 3 days searching about this photo. Physiological is increase in heart rate, and blah blah blah. Metabolic is glycolysis. This approve, you can give it to anyone. He asks you about this is metabolic, and this is physiologic. Increase in heart rate and the glycolysis. I think it's clear, no doubt about. Yeah. Next question.
A 58-year-old man underwent an emergency appendectomy. Which of the following physiological parameters are consistent with the sepsis? So this guy is.
I want you, what will you search in sepsis? If you found question asking you a heart rate, systemic vascular resistance, and cardiac output.
In sepsis,
what
usually I'm looking for the dilated vessels, which will
heart rate. What you will search here in the heart rate?
Increased heart rate.
So you have one
B, C, and E.
B, C, and E, and then go. What will you find in the systemic vascular resistance?
Low vascular resistance.
Low vascular resistance. So here.
No, I will exclude this one.
Exclude, and here include, and here include. So C and E. Cardiac output.
It will be increased.
It will be increased. It will be increased because of the tachycardia. By the way, it will be increased first, and then it will be decreased because the low volume. By the way, but keep in mind it will be increased. Don't if you go for part B, you can find this first will be increased and will be decreased because the severe dilatation will decrease will decrease the compliance of the veins. The compliance of the veins will decrease the preload and will increase the venous return, and then will decrease the cardiac output in spite of tachycardia. But for now, for part A, cardiac output will increase. Okay.
Yeah.
So this is the way how to think. If you want to read all this, the same, some questions like the question of ABG and the question of shock, you have to put in your mind one parameter by time. Go for the question. He said he started here with the systemic vascular resistance. So you put in your mind systemic vascular resistance in hypovolemic shock. It will be increased systemic vascular resistance. What is the answers? 1, 2. So by exclusion, I'll keep C and D. And then next parameter is the heart rate, increase or decrease. In hypovolemic shock, there will be tachycardia, just to increase. One increase and one decrease. So this is my answer. This is the way how to solve the question of shock. To know the question of shock. Okay?
Okay.
Clear about this?
Yes.
Okay. Next question.
A 50-year-old man with a 30-year history of pancolitis undergoes surveillance colonoscopy, which reveal a plaque-like lesion in the descending colon. Biopsy reveal a pre-malignant change. What is the name of this pre-malignant change? Anaplasia, dysplasia, hyperplasia, metaplasia, neoplasia. The pre-malignant is dysplasia.
Dysplasia, exactly. Pre-malignant is dysplasia. Okay, and then carcinoma in situ, then cancer. This is the sequel: normal, hypertrophy or hyperplasia, then dysplasia, then dysplasia and carcinoma in situ can be sometimes they are merged in one word, and then go direct if there is crossing of the basement membrane or emerging of the basement membrane. Okay, it will be go for cancer. So pre-malignant is dysplasia. Pre-malignant is dysplasia. Next question, very common question also in the exam.
A 60-year-old man undergoes cystectomy for a bladder carcinoma. During surgery, the ureters are identified. On which region of the bladder do the ureters pierce the bladder wall? Usually it pierces the bladder from the posterior or base.
Perfect. Perfect. Sometimes posterior, sometimes give you base of the bladder. Sometimes posterior and sometimes base of the bladder. Keep sometimes when you want to change the question or the change the answers and change the scenario, he plays with this word, posterior surface, or sometimes the base of the bladder. Sometimes the trigone, but I didn't see before, but it is in the apex of the trigone. Apex of the trigone, which is on the base of the bladder or posterior surface of the bladder. Next question.
A something-year-old patient in the intensive care unit has a tracheostomy performed via the second, third, and fourth tracheal ring. Which intervening structure is most likely to require transaction? Anterior jugular vein, inferior thyroid vein, sternothyroid muscle, thymus, thyroid isthmus. Thyroid isthmus.
Exactly. Here is a photo. Can explain for us what is when we do a tracheostomy. We have to divide the thyroid isthmus to, because thyroid isthmus is lying on the tracheal ring from 2 to 5, and it is the site we do the tracheostomy and endotracheal and tracheostomy tube. Next question.
A 23-year-old man is assaulted and sustains a stabbing injury. To the left groin. The wound is cleaned and a simple dressing applied. 6 months later, the patient returns with a pulsatile swelling at the site of injury. The most probable lesion present is abscess, false aneurysm of the femoral artery, lymphocele, mycotic aneurysm of the femoral artery, saphenous varix. A wound at this highly vascular area, and he come back with a pulsatile mass. This is a pseudoaneurysm or false aneurysm of the femoral artery.
Yes, exactly. By the way, all these complications can happen in a trauma. Okay, stabbing wound trauma can have an abscess, and the abscess can be pulsatile if it comes over the village. It can has lymphocele of injury of lymphatic vessels, can have mycotic aneurysm, can have saphenous varix, can be dilated after trauma, do anything. But here is he asking, he was accurate to ask what is the most probable. What is the most probable? He doesn't say what is the diagnosis, because abscess can happen. Okay, you have in part B a patient with recurrent. He patient is addict and has a recurrent injection of himself for addict materials and morphine and tramadol and so on. And the patient came with a groin abscess, and he diagnosed by his GP as a groin abscess. And when he was sent to the general surgeon to open the abscess, the general surgeon discovered that it's not actual an abscess, but it gives a picture of an abscess, but it's actually an false aneurysm of the femoral artery, and it is infected false aneurysm of the femoral artery. Okay, so abscess can happen and can give pulsation, and false aneurysm here, that means it is not inflamed, but the other patient came with inflammation, redness, and hotness, and some discharge. You can see serous discharge from the pus, and it was an inflamed and infected false aneurysm of the femoral artery. and it is mostly after trauma in a young patient. Okay, next question. Nice question about ABG.
A 72-year-old man with a body mass index of 18.4 has not eaten for 4 days following the removal of an adenocarcinoma from his descending colon. His urea is found to be 12 millimole per liter, which is high according to the normal reference, and creatinine of 346, which is high according to the normal reference. A blood gas profile is ordered. The most likely set of results would be, so this is a guy who is not eating with a low body mass index with high urea and creatinine.
What do you expect his ABG to be?
Yeah, I will expect him to be in a state of metabolic acidosis.
Exactly. So what do you expect to find in the pH?
The pH will be low, so I will exclude out D and E.
Okay, and
I will expect the bicarb to be low, yes.
Okay, so
I will end with A.
exactly, this is a very nice. So you go with A, B, and C. Can be if the patient was compensated. A and B is acidosis. C is compensated, or yani it is in the borderline with acidosis. So you can keep this answer, and then you can go for the bicarb. You will find only A has a low bicarb, so A is the cap. Don't read all the answers in ABG. Don't read all the answers like this. I like the vertical manner. Okay, I make a very good lecture a few months ago about the ABG and how to solve the question in ABG. It was really, we are solving in a vertical manner by exclusion. So we are asking, searching for one ABC, and then go for the next parameter. What is the parameter most important in metabolic? Is the bicarb. So you can skip oxygen and CO2 and then go. Maybe you find two. Okay, so it is acute problem or chronic problem, chronic problem. So what I go for the 36, so it will be compensated, or I go for 30, which is not compensated, and so on. But here I think it's clearly solved like metabolic acidosis, and the other things, no, this is acidosis, but bicarb is not normal. The bicarb is high, so it is go with alkalosis, so it is not right. Okay, now we'll start new. Who is ready? Would you like to take 5 minutes break?
So like,
Okay, it will be nice to take a break.
5 minutes break and go. And who is ready to continue?
yeah,
I'm ready to continue.
me too.
After the break.
Who? Doctor? Dr. Mu'tasim? Dr. Mu'tasim and Dr. Dafer after the break.
Okay.
Okay, back again to continue with Dr. Dafer. Okay, Dr. Dafer, تفضل.
A 16 years old boy is hit by the left side of the face by the ball. There are no broken bone, but the bone complain of numbness of the face below the eye, which nerve must likely seem to be compromised. Obtusent, facial, glossopharyngeal, infraorbital nerve, and zygomatic. So it is D.
Infraorbital nerve. Clear, as we can see. Infraorbital nerve supplies the area below the eye above the maxillary sinus. Okay, next question, and the same picture. We say it is very, very important.
Yeah. A 74 years old man who has undergo emergency major abdominal surgery 2 days previously is noted to be confused, He has been furosemide for mild heart failure. His plasma sodium 122 millimole per liter. Inspect the fluid chart. Show that he has been writing up for 1 liter for 4-hourly intravenous 5% glucose infusion. What is the most likely cause for this hypoglycemia? An ACTH, response to the surgery, excessive sodium-free intravenous fluid administration. So it is DSB.
Exactly. Patient on furosemide. So the patient already the patient is losing
Sodium.
is losing sodium and is losing high sodium, minus 25%.
Yeah.
And you are giving the patient sodium-free fluid. We said always, sometimes in post-operative or patient in surgery, we always give 1 liter of normal saline plus 1.5 to 2 liters of dextrose. Any one of these you will not give, the patient will have an electrolyte imbalance. Here is a patient had excessive sodium-free intravenous fluid administration that makes his complication, and the patient go for hyponatremia, and the hyponatremia will give him brain edema and lung edema, and the patient can go have some hypoxia and some confusion and drowsiness and dizziness as well. Next question.
The Cori cycle is important for lactate metabolism in the septic surgical patient. It's used to describe the pathway in which the glucose metabolizes anaerobically to lactate in one tissue and the lactate converted back to the glucose in the another. Which one of the following rely on the cycle to meet all of its energy feed? Erythrocyte, hepatocyte, leukocyte, osteocyte, pneumocyte. It is erythrocyte.
Erythrocyte depend on energy produced by the Cori cycle to meet its energy requirements through Cori cycle. This question came twice, by the way. Repeated again last year, I think. Repeated in January, I think, 2020.
Yes.
Cori cycle depends on, yes. Next question.
After receiving an intramuscular injection in the buttocks, 25-year-old man complained of inability to eversion his feet. Which nerve is most likely to be injured? Common peroneal, inferior gluteal, pudendal, superior gluteal, tibial component of the sciatic nerve. So it is A, common peroneal fibular component of the sciatic.
Okay, eversion of the foot. Eversion of the foot, common peroneal.
Yeah.
And is the nerve for this.
Yeah, I think if we
common
want to,
peroneal. Yeah. Sorry.
if we want specific, it will be the superficial branch of the common peroneal.
Exactly. I'm just going to say, sometimes you find this is the common peroneal. Sometimes you will find this common peroneal, and sometimes he give you the specific injury. If he tell you the superficial peroneal, so this is responsible for the everter, and don't forget about the superficial peroneal, what it
sensory
supply dorsum, all the dorsum of the foot, so it has more sensory dorsum of the foot, and the lateral compartment, which is a vertebra. Deep peroneal nerve, just give a small area, the first wave space, and give all muscles of dorsiflexors and ankle flexors of the leg. Okay, sometimes he's more specific and tell you lots of sensation on the dorsum of the foot, unless or except small area on the first web space, or sometimes it gives you loss of sensation over the left first web space. Very common question in the exam, and it came to me in 2019 April. This question came to me, and I think the answer was, I think the deep peroneal, because he said in the first web space loss of sensation. Very common, but here is because the injection is high in the buttocks. That's why it go direct for the common peroneal, because the bifurcation will be below the knee. So sometimes trauma to the knee, and he asks you about, if you want to ask about superficial or deep peroneal, the trauma will be here in the knee or at the fibula, outside at the fibula. Next question.
73 years old man with history of irregular bowel movement presented with the dysuria, hematuria, and E. coli. Urinary tract infection CT scan show a mass involvement to the sigmoid scan of the bladder and the bladder. What is the most common causes of the presentation? Adenocarcinoma of sigmoid, colonic diverticular disease, Crohn's disease, transitional cell carcinoma of bladder, ulcerative colitis. So it is a colonic diverticular disease.
Chronic diverticular disease. This is old patient, irregular bowel movements, present with dysuria, history of irregular bowel, dysuria, and hematuria and Escherichia coli. He is going for infection. All this, you want to direct your thinking about infection, irregular bowel habits, so the patient has repeated constipation. Patient has some dysuria and hematuria, so there is gas in the urinary bladder. And then Escherichia coli, which is a common pathogen or a very common pathogen in the intestine, and you can find it in the urinary tract plus the hematuria. So this is a picture of colovesical fistula, and the commonest cause of this picture, the commonest cause of left iliac fossa pain on old age is diverticulitis or diverticulosis or diverticular disease or diverticular mass, as there is no in the scenario. Sometimes one told me, why doctor, it is not an adenocarcinoma with fistula. If you have an adenocarcinoma with fistula, if you have cancer with fistula, to reach outside, you have to, this cancer to reach the serosa, to be staged. If it is adenocarcinoma, you have this cancer to be stage D or stage 4 to reach this. So the patient passed with many complications like cachexia, like bleeding, like loss of weight and anorexia, and maybe intestinal obstruction till the cancer reach the to the serosa and start to invade adjacent organ and start to make a fistula. All this is not mentioned in the scenario. You need stage 4 or stage stage D according to Duke's classification to have this picture, but it's not here in the picture. The picture here is only mass, some pain, and hematuria and Escherichia coli infection. Okay, so this is the most common cause for this picture is chronic diverticular disease with colovesical fistula. Next question.
7 years old man in the recovery area, I received 28% oxygen by the mask. ABG show the pH acidotic, the PO2 it's 12 kilopascal and PCO2 it's 12 kilopascal. So reduced sensitivity to which of receptor and is most likely to be responsible for this blood gas. So we're giving oxygen and we're looking for the PCO2, its increase to adrenergic receptor, baroreceptor, central receptor, G receptor, lung citrating receptor. It goes with the C, central, because it's affected by the PCO2.
Exactly. So we are searching here. Baroreceptor is a mechanical receptor, adrenergic receptor, no. G receptors, no. Lung stretch receptors is not affected by the rate of respiration and the stretch. Only which is chemoreceptor, which is affected by the change of CO2 mainly, and sometimes with the pH, is the central chemoreceptors. Next question.
A 76 years old woman fall and sustain an intratrochanter fracture neck of femur. Follow operation fixation. His recovery is prolonged and she is discharged to the rehabilitation unit 6 weeks later after her original operation. She is readmitted. She is drowsy, hypotensive, and bradycardia. An ECG show low voltage complex of the QT interval underactive of which of the following gland give the best explanation for the clinical picture: adrenal, pancreas, parathyroid, pituitary, and thyroid. So it is parathyroid glands.
Parathyroid gland. Parathyroid gland give you what?
Give
Low
you
voltage? Okay.
Yeah.
Low voltage complex. Why you choose parathyroid gland?
because it is affected the calcium,
Okay.
so which will lead to decrease the calcium, so will lead to the prolonged QT interval.
And low voltage complex.
Mm.
Can you read this, please?
Yes, I focus for this. Common ECG change in the hypothyroidism are bradycardia, low voltage complex, ST segment depression, QT interval lengthening, and increased QT this depression, flattening or inversion of T wave, which reflect the prolonged cardiac action potential.
What do you expect your answer?
So we change to thyroid.
Exactly. By the way, I'm the first one who corrected this question because I didn't yani. Okay, prolonged QT interval, I completely agree with parathyroid, but low voltage complex, I didn't see it in any hypocalcemia. So I have to search about low voltage complex. I found this, that hypothyroidism is the most common cause of low voltage complex or low voltage QRS. So this should be corrected in Fawzia sheet to thyroid, not parathyroid. Okay, very important.
Okay.
Clear about this?
Yes.
Okay. Next question.
36 years old man fall on his outstretched right. Examination revealed tenderness in the anatomical snap box. Which of the following tendon form the boundary of the anatomical snap box? Abductor pollicis brevis, extensor carpi radialis, extensor carpi radialis longus, extensor indicis, extensor pollicis longus. E.
Extensor pollicis longus.
Yeah.
Okay. Here is the boundaries of the anatomical snap box. Extensor pollicis brevis and abductor pollicis longus forming the lateral or the anterior wall. Lateral or sometimes tell you the anterior wall. Extensor pollicis longus means the posterior or the medial wall. We are talking about the anatomical position. In anatomical position, this structure, the brevis and the abductor pollicis will be anterior and lateral. The extensor pollicis longus will be posterior
And medial.
and medial. Posterior and medial. Sometimes he asks which one of the following is which one of the following is a boundary, and sometimes which is the following forming the lateral wall or the anterior wall or the posterior wall or the medial wall. You have to know this. Extensor brevis, the abductor longus, forming the anterior or lateral wall. The extensor pollicis brevis, extensor pollicis longus, forming the posterior or medial wall of the anatomical snap box. Clear?
Yes.
Okay. Next question.
65 years old woman with metastatic breast cancer is admitted to the hospital confused and actually unwell. With nausea and vomiting, her vital signs are within the normal limit. What is the abnormal in the most of the contributed her clinical condition? So admitted with breast cancer, so it's hypercalcemia. Hypercalcemia. Okay.
Okay, hypercalcemia is the most common thing in metastatic breast cancer. Okay, very important, by the way, this table. This table is very important, very important. يعني primary hyperthyroidism, renal failure, and osteoporosis, osteomalacia, and cancer. All these questions come in the exam. Okay, osteomalacia, he said before, patient presents with low calcium level and low phosphate and high alkaline phosphatase. This is osteomalacia. Sometimes patient with fracture and in blood tests found normal calcium and phosphate and alkaline phosphatase. What do you expect? Osteoporosis. What is the pathology of osteoporosis? Decreased bone matrix, decreased calcium, increased phosphate, decreased phosphate, and so on. He wants to know you that osteoporosis, the patient will have a normal calcium level. In osteoporosis, the patient losing a bone matrix, not a decrease in ossification or mineralization of bone. Mineralization of bone, decrease in mineralization of bone happened only in osteomalacia. But in osteoporosis, the bone has normal mineralization, but less in matrix. Less in matrix. The bone matrix itself is less, but wherever there is bone matrix, it has a good mineralization. Okay? Then, multiple myeloma, high calcium, high phosphate, but normal alkaline phosphatase, and this can differentiate it from bone metastasis. Both of them have high calcium and high phosphate, but alkaline phosphatase is high in multiple myeloma, is high in bone mets, but it is normal in multiple myeloma. Clear about this?
Yeah.
This is the most important things you have to differentiate during your study. That osteomalacia and osteoporosis, you have to differentiate between this, and this is, and osteomalacia is high. In multiple myeloma, is how to differentiate between multiple myeloma and bone mets by this. Both of them has hypercalcemia and hyperphosphatemia, but the alkaline phosphatase increase with bone mets. Simply, alkaline phosphatase you can find in two important structures. High. What you expect?
Obstructive jaundice, one of them, and bone turnover in cases of osteomalacia and Paget's.
The most common two sites that you have in alkaline
high alkaline phosphatase, it comes from any bone pathology or any biliary pathology. The most common two sites. Okay.
Okay.
Yani for your information, but you may face it in part B or not. There is something called the placental alkaline phosphatase, but you will not be asked about. According to the MRCS, you have two main pathology. Any pathology in the bone, like osteomalacia, here is no pathology in the bone, by the way. Normal bone, but listen matrix. Pathology in bone, you will find multiple myeloma, you have osteolytic lesions, you'll find, but in bone mets, you have bone destruction, you will find high alkaline phosphatase, biliary tract, any obstructive jaundice, and Klatskan's tumor or cholangiocarcinoma, you'll find alkaline phosphatase is very high. Okay?
Okay.
Okay.
Next question.
A 4-year-old boy presented with emergency department with 2-day history of fever, difficult walking and unable to weight bear on the right leg. He has been on oral amoxicillin 250 milligram 3 times per day for the chest infection over the last 5 days. He is irritable with the temperature 39.4 centigrade. He does not allow exam and keep his right hip flexion and abduction. Blood test reveal white blood cells 12,000.3 and C-reactive protein is 146, hemoglobin 11.3. What is the most likely diagnosis? So it is either A, acute avascular necrosis, dislocation of the hip, birth disease, septic arthritis, lip, upper femoral epiphysis. So it is D.
Okay. Why do you choose
D?
D, septic arthritis? Because
it's
all of this.
All, yeah.
All of this. Because all of this is an infection. It is not dislocation. It is not Perses disease. It is not anacrosis, it's a 4th year. It is not slipped femur epiphysis. Slipped femur epiphysis is a patient with
obese.
About 11, 12, 13, 14 years. Okay, and obese and limping. There is no fever, there is no infection, there is no high white blood cell count, there is no high C-reactive. Kocher criteria. Exactly, Kocher criteria.
A, B, C, D, E.
Okay.
Okay.
Next question.
35 years old woman presented with a recurrent peptic ulcer. She is on the proton pump inhibitor and previously received H. pylori eradication therapy. 3 months ago, which of the following is most likely raised in the venous blood test? Cholecystokinase, gastrin, histamine, pancreazyme, and secretin. It's gastrin.
Gastrin. Okay, guys, this is gastrinoma. This is gastrinoma.
Yeah.
And in the exam and in MRCS in part A and part B, recurrent peptic ulceration, he want to listen to the word gastrinoma or high gastrin level in the body. So he want to mention in your mind, this is common is common. Common is common. When a patient comes to you with repeated or recurrent peptic ulcer,
unexplained by heavy smoker or maybe alcohol drinking or this patient, if he has this problem, first thing you have to think in your mind is high gastrin level, high gastrinoma, even from pancreatic or ectopic gastrin secreting tissue. Okay.
Okay.
Next question, and I always say this photo is very, very, very important.
Yeah.
Okay.
55 years old man presented with the backache. Neurological examination revealed lack of the extension of the leg grade 2. Which of the following spinal cord system are likely to be involved? L1, L2, L3, L2, L3, L4, L4, L5, S1.
What you expect? What you expect? What we are searching? Left grade 2, grade big,
L4, L5.
left big 2 or left grade 2. You are searching for
L4, L5.
You are searching for L5.
L5, yeah.
Okay, you are searching for L5.
So it's
So
C.
it is
C.
C. Simply. Okay, simply. Maybe this may help in part B as well. Okay. Flexion of the thigh, L2. Extension of the knee, L3. Dorsiflexion of the foot, L4. Big 2, L5. Plantar flexion, S1. Okay.
Yeah.
L2, 3, 4, 5, S1, and so on. This is the most important what you need, because in part B, when you have neurological lower limb examination, you will be asked about this. Tell the patient to raise his leg against resistance. He will ask you the root for this, the root origin for this action. It will be L2, and tell you the patient, please extend your knee against my resistance. What is the root for this? It will be L3. And you ask the patient, please, and you are checking the power for the patient, and he asks you, okay, L4, he tell you the patient, okay, can you hold your leg, your foot against me, and you try to extend the foot, and he dorsiflect the foot. This is the action of L4, and then you ask the patient to resist flexion of the big 2 by dorsiflexion of the big 2. This is the action of L5, and S1 is the plantar flexion. Tell the patient to push against my hand. This is the plantar flexion of S1. Keep this in your mind. From 2 to S1. Okay, so when he talking about dorsiflexion of the big 2, dorsiflexion of the big 2. Okay, so you are asking about L5. So search what in all of these has L5. You'll find only this. Clear?
Yes.
Okay, next question.
A 34
Again.
years old man is seen in emergency department with the fibular fracture. Fellow football match. On examination, he is noted to have a loss of foot eversion. Which area of the skin should examine to confirm the loss of the cutaneous distribution of the effective nerve? Along the lateral aspect of the foot, along the medial aspect of the foot, across the dorsal surface of the foot, and on the plantar surface of the foot, over the heel. So what is
What is a nerve injury here?
Yeah,
loss of foot eversion.
everything superficial femoral,
Superficial. And
perineal,
so what area, what area will you
dorsum,
ask?
dorsum of the foot.
Okay. Dorsum of the foot. Simply in your mind, you will search. I think this is a question who came for us in the exam, or the same question. They are playing with the deep peroneal, superficial peroneal, and common peroneal. Playing with all these questions in the exam. Okay, the patient lost dorsiflexion of his hand, or the patient has a dropped foot. Sometimes the patient has a dropped foot. Okay, and what will you expect to find in sensory examination? Okay, next question.
68 years old man with insulin-dependent diabetes presented to the pre-administered clinic prior to the surgery for rectal carcinoma. His creatinine found to be 590. He is referred to the renal unit where the measurement of the glomerular filtration rate is done. Which of the following best describe why inulin could be used to measure glomerular filtration rate? It is filtered are not absorbed, yes. It's filtered and reabsorbed. It's filtered, secreted, reabsorbed, no. So it is first A.
Exactly. Put in your mind the most common question about glomerular filtration rate. As we know, glomerular filtration rate is measured by inulin. Okay.
Yeah.
Glomerular filtration rate. Good. The other one is the
renal blood flow is
renal blood
para-aminohippuric
flow
acid.
is para-aminohippuric acid. Para-amino, PAHA. PAHA is the renal blood flow, and inulin is the glomerular filtration rate. Why? They always ask why, especially inulin, because it is filtered and not reabsorbed. That's give you accurate results about the glomerular filtration rate. Okay.
Okay.
Next question.
A 60 years old man presented with the 1 month history of headache, confused, present onset of right side hemiparesis. A CT scan demonstrated 4 cm more plus 4 cm lesion with central necrosis in the left frontal lobes. It seemed extra across the midline along the corpus callosum. There is extensive edema around the lesion. Which of the following most likely be diagnosis? Central neurocytoma, epidendroma, glioblastoma, meningioma, oligodendroglioma. So I goes with the C, glioblastoma.
You go with C, glioblastoma or glioblastoma multiforme. This is the most aggressive type of glioblastoma, and it is sometimes it presents with cavitating lesion. Okay. Glioblastoma multiforme is the most aggressive form of glioblastoma. And by the way, they like it so much in the brain tumors. They like glioblastoma, even in part B. When he asks you what is the most common tumor in this patient, you do expect glioblastoma multiforme is the most common and most aggressive tumor you can expect to happen. Okay.
Yes.
Next question.
Dr. Rami,
Would you like to continue, or yeah?
Before we leave the previous question, the commonest CNS tumor in children was I think astrocytoma or what?
Astrocytoma. Astrocytoma.
And previously, I think it was another one, other type.
It
You
was, I
mentioned,
think,
Yes,
it was, sorry? It was, yes,
medulloblastoma.
I think so. But just keep the newest one. Don't
Astrocytoma,
confuse.
astrocytoma.
Don't confuse yourself.
He mixing between the EMRC and Fawzia Sheet, so that's good.
Yeah.
Yeah.
Fawzia Sheet is more important than MRCS, by the way.
Yeah.
Okay. Fawzia Sheet is more important. Yani about 30 question to 40 question of this sheet come every year in the exam. Please concentrate in this more and more important. Okay, next question. Dr. Dafar, anyone want to continue? We still have about 30 questions. Dr. Muhannad, are you ready?
Yes, yes.
Okay, Dr. Muhannad will take some and Dr. Mu'tasim can take some. I don't know where is Dr. Ahmad is, he sleep or still with us. And I want to finish the 30 question within 30 minutes. So
Almost,
not to make the Zoom.
Right.
Almost, yes.
Yeah.
Okay, Dr. Ahmad. Good enough, Dr. Ahmad.
Good enough.
Okay, Dr. Muhannad, تفضل.
Okay, a 65-year-old woman present with a 2.5 cm diameter mass in the upper outer quadrant of the left breast with associated axillary lymphadenopathy. A core biopsy is taken, which confirmed the presence of carcinoma. Which of the following types of carcinoma is this most likely to be? So this is a unilateral mass in the outer upper quadrant, 2.5 cm, with associated lymphadenopathy.
Sorry. So
I
he is
will go
asking
with
about what is most common likely
I
to
will
be.
go with the invasive ductal carcinoma.
Okay, here is he gives you no more that except this is mass or lump in the upper outer quadrant, lymphadenopathy, and by biopsy gives. Here is asking you generally what is the most common cancer in breast cancer in females. By the way, upper outer quadrant is the most common site, up to 60%, and invasive ductal carcinoma more than 50% of all breast cancers. Yani if in every about 20 breast cancer, in every 20 breast cancer, or keep it 10 breast cancer, you can do and search for the histopathology, you find about 7 to 8 invasive ductal carcinoma. Very rare to find any other tumor, medullary carcinoma or any or mucinous or tubular or no invasive ductal carcinoma is almost most of the, I can tell you even in our countries it's more than 70%, not only 50% or 55%. So invasive ductal carcinoma is the most common breast cancer you can find. Okay.
A 26-year-old man is admitted to the emergency department with multiple peripheral fractures. He is clinically shocked, which is the structure responsible for the first hemostatic response to a fall in systemic arterial blood pressure. So he is in a shock, and he wants to know the first hemostatic measure in response to the hypotension. Either it will be autonomic or hormonal, but usually hormonal is very slow, so I can go with the baroreceptor.
Okay, mechanical baroreceptors. Mechanical baroreceptor is the first, as you said, neurological or mechanical response will happen due to hypotension. The stretch receptors and the baroreceptors on the aortic arch and carotid, mostly on the aortic arch and the carotid bifurcation will be sensed and the stretch will be less. So the back, the negative feedback for the regulators will
activate the sympathetic and deactivate the parasympathetic.
Exactly. Activate sympathetic and parasympathetic, and this will be the first mechanical or neurological first hemostatic response that happened in the arterial blood vessel and in the arterial blood pressure. Baroreceptors response. By the way, this question is very common, and I can remember it 2-3 times and recalled and came for me in my exam. Okay. Exactly, as you said, baroreceptors. Here is the explanation about what will happen by the baroreceptors. Next question.
Vitamin K is required for normal blood clotting. Which one of the following statements is true about the effects and availability of vitamin K? It affects the platelet function, causes bleeding if taken in excess, is provided only by fresh food, is depleted by broad-spectrum oral antibiotics. Vitamin K absorption is affected by resection of the terminal ileum. I'll go with the vitamin K is affected by the resection of the terminal ileum. And is depleted by broad-spectrum oral antibiotics. I will go with E.
Exactly, is affected. Is affected by the resection of the terminal ileum. Why?
It's fat-soluble vitamins.
Anyone has explanation? Dr. Dafer. This is one of the tricky questions, by the way, in the exam. Dr. Ahmed. Dr. Dafer.
Yeah. For vitamin K, it's mostly absorbed in the terminal ileum. This is one of the fat-soluble vitamin. It's absorbed in the terminal ileum. This is emulsified by the bile. So when you resect the ileum, we have deficiency in this.
Yes,
same explanation. The site of vitamin K absorption is the terminal ileum. So when you resect the terminal ileum, you affect the vitamin K absorption. So decrease vitamin K, affecting clotting.
It is decreased absorption of the bilirubin in the B12. It is responsible for metabolism.
Okay. Terminal ileum is a site of absorption of about 95% of the bile salts for enterohepatic circulation. And affection of bile salt absorption in the enterohepatic circulation will affect fat metabolism and fat and vitamin and fat soluble vitamins as well, including vitamin K. Clear?
Yes, it's clear.
Okay, he wants you here to think about the enterohepatic circulation of bilirubin and bile salts. Put in mind that bile salt, about 95% of bile salt is absorbed from the terminal ileum. And that's why affection of the terminal ileum will affect the enterohepatic circulation of bile salt. And this patient, we should receive synthetic bile salt
or like something like cholestyramine, something like this, not to affect the absorption of the fat soluble vitamins, especially vitamin K.
But doctor, because what I know also is that the vitamin K, when you are using sulfonamides or sulfur-containing antibiotics or broad spectrum like cephalosporins, it affects also the absorption of the vitamin K by depleting the norm the normal flora that
which
enhancing
enhance the absorption of vitamin K. But you are talking about specific antibiotics, yeah?
Yes.
You are talking about broad spectrum antibiotics. Which will be more effective for this? Which patient will be affected more? Which patient will be affected more?
The one with
any normal patient can take broad spectrum antibiotic, and even the drugs you mentioned can go for low vitamin K.
No.
Did you see any patient take sulfonamide for 1 month and he suffered from vitamin K problem? No,
I didn't.
It will affect vitamin K, but it will not make this patient have availability of vitamin K will be affected to an extent. He will have a chronic problem of vitamin K.
Yeah.
Okay. Thank you. Okay, next question.
In septic shock, this one I think it's the same question. It met me before. In septic shock, norepinephrine or noradrenaline is used to increase the systemic vascular resistance. This action is a result of the stimulation of which of the following receptor? Alpha 1.
Alpha 1. Norepinephrine mainly on alpha 1. Mainly on alpha 1. Epinephrine mainly affect beta 1. All of them, by the way, all of them non-specific, but they have action on more receptors than the other one. Epinephrine and norepinephrine, by the way, are non-specific. Unlike dopamine, unlike dopamine. Dopamine mainly on beta 1, mainly on beta 1, and has no effect on an alpha, or just mild effect on alpha and beta 2. But epinephrine affects beta 1, primarily affect beta 1 and causing tachycardia. Norepinephrine primarily affect alpha 1 and causing vasoconstriction, primarily affect. And dobutamine, and this is the most common questions, by the way, dobutamine mainly act on beta 1 to increase the heart rate, the same like epinephrine. But the most common question that come here is mostly asking about epinephrine and dobutamine. Dobutamine is very common. We give in patient with septic, patient with shocked patient, in patient with shock. We're trying to give, especially in cardiogenic shock, we try to give dopamine and dobutamine and norepinephrine as the same. In patient with septic shock or patient with decreased systemic vascular resistance, we try to give norepinephrine to increase systemic vascular resistance. Next question.
A 10-year-old child presents with progressive facial weakness and squint. On examination, there is a lower motor neuron, facial weakness, and failure of abduction of one eye. An MRI scan shows a small intrinsic mass lesion within the central nervous system. Where is the
most likely to be located. So this guy is having progressive facial weakness and squint, and he is having failure to abduct his eye.
What nerve?
So right now we are talking about the sixth cranial nerve
And
the progressive facial weakness.
from its name,
Yeah, facial nerve.
facial. We are talking about facial weakness. What is responsible for the facial muscles of facial expression and muscles of the face is mainly supplied by facial nerve. Motor. Facial nerve is a motor. So muscles of facial expression is supplied by facial nerve. And then he told you also
Bones.
the patient has a squint. So what this you are talking about abduction, this which nerve?
Sixth cranial nerve. Abducent.
Abducent. So you are taking about 6 and 7. And according to our table, 2, 2, 4, 4. So the first 1 and 2, 3, 4, then 5, 6, 7, 8 through within the bones. So our 2 targeted nerves are in the bones. Clear? Put this picture in your mind. Don't forget it. Okay.
Okay.
Facial and abducens ولا facial and vestibulo-ocular?
Abducent. 6 and 7. 6 and 7.
Okay.
Facial, here is facial. Facial weakness, this facial nerve. Failure of abduction, this abducent nerve. So we are taking about 6 and 7 cranial nerve, which is related to the bones. Next question.
A 65-year-old man with a history of ischemic heart disease has an abdominal perineal excision of the rectum, after which he is stable. 2 days later, he is clammy, has cool preference, a tachycardia, and a blood pressure of 80/60. His temperature is normal. What is the most likely cause? So, a guy with ischemic heart disease undergone abdominal perineal resection, ABR, of the rectum. And now, after 2 days, he is clammy with cold periphery or cold preference, tachycardic, and hypotensive. His temperature is normal, and this is excluded the septic. And his preference is cold, not warm, also excluding the sepsis. And right now I'm between the hypovolemic and the cardiogenic.
Okay, hypovolemic shock. Hypovolemic shock. Cramp has cold periphery, tachycardia, blood pressure is this. Hypovolemic shock means you have losing volume, sir? Yes? Okay, so what is here telling you about his temperature is normal? So this patient is not losing. What is nothing here about losing any blood volume. There is no bleeding, there's no peritonism, there is no anemia, there is no even low temperature. Patient who is lost blood or hemorrhage, mostly this patient has a low temperature, or if the patient has internal bleeding and infection, this is abdominal perineal after 2 days. If the patient has peritonitis due to internal hemorrhage, you'll have high temperature. So the problem is not in the volume. So what is the other choice with you?
I will go with the cardiogenic. It's the same features of the hypovolemic, but without any apparent blood loss or volume loss.
Okay. Does anything in the scenario can target your thinking about cardiogenic shock?
Ischemic heart disease.
Exactly. Any point he gave you in the scenario really is answering and giving you a very clear answer for your question. What you said is completely right. Clammy, cold periphery, tachycardia, low blood pressure. So he wants you to go with if we don't have ischemic heart disease, by the way, both are right. But if he told you the patient has abdominal pain or the drain is bringing this, so you go for hypovolemic shock. Patient is ischemic heart disease, you go for cardiogenic shock. Very important. By the way, this picture is very nice. If you want to study shock, this is hypotension, tachycardia, decreased cardiac output. Okay, the patient has tachycardia and decreased cardiac output because this is non-effective pump. So cardiac output will be decreased and as well systemic vascular resistance. And hypovolemia, the patient has high hypotension, tachycardia, the same. Decreased cardiac output because there is low volume. There is loss of volume of blood. Loss of volume of blood. Okay, so both of them can give you the same picture. But both of this is the patient has chest crackles. Okay, the patient has chest crackles because a cardiogenic shock will cause pulmonary edema. So put in your mind this. Neurogenic shock, the patient will have bradycardia. And his skin will be warm, the same like septic shock. So neurogenic shock and septic shock, both of them, the patient will have warm skin and flushed skin. Both of them will have warm and flushed skin. But neurogenic shock, the only shock the patient will have bradycardia. Neurogenic, bradycardia. And septic shock, the patient will have tachycardia. But both of them has a dilated blood vessel because both of them has decreased vascular resistance. Both of them has decreased cardiac vascular resistance. So both of them will have dilated vessels. So both of them will have a warm skin. But here will be warm and dry because the neurogenic will affect the sweat glands, the supply for the sweat glands, so there will be no sweating. But here the patient sometimes will be with wet hand or warm and watery hand. Clear?
Yes.
Okay, so this patient will have cardiogenic shock. Next question.
A 55-year-old man present to his general practitioner with a 4-month history of feeling tired. The general practitioner notes breast enlargement. Investigations revealed TSH low compared to the normal range and free T4 is low compared to the normal range. So he is having low TSH and low T4.
So what you expect this patient to have?
I will expect this patient to have a secondary hypothyroidism.
Second hypothyroidism. Don't forget this one. Don't forget this one. If this is low, this will be high. If this is high, this will be low. Okay. The primary problem is this is very low. It will be increased by increasing this, and if this is high, it will make a negative back pressure. But if both of them is low, so the problem is here. If both of them is high, so the problem is here. So secondary hypothyroidism, secondary to a cause in the pituitary gland.
Yeah. Secondary to a cause decreasing the thyroid stimulating hormone.
Okay, from
what?
Okay, look to this table. Look to this table. If the patient has a low T3 and low T4 and low TSH, so both T3, T4 low and TSH is low, this is secondary hypothyroidism. If the patient has all of them high, so it is secondary hyperthyroidism. Okay, go to the primary. Primary hyperthyroidism due to high thyroid enzymes, which will give a negative feedback to make low TSH. If the patient has primary hypothyroidism, means that the T3 and T4 are low, so the patient will have a compensatory increase in TSH. Compensatory increase in TSH. Okay. If the patient, and this is common questions, and started to become common in the last few years, maybe last year, I think came one or twice last 2 years. If the patient has normal thyroid functions, but T3 or T4 is high, this is called subclinical. Subclinical. So this is normal and this is high. When high TSH happen here, happens with what? Happens with hypo. When there is hypothyroidism, TSH is high. Here is normal, but still high. So this something like, he misreading this like low. So this is subclinical hypothyroidism, and the other is the same, is subclinical hyperthyroidism. This TSH is decreasing, like here is high, but actually it is normal. So we call it subclinical hyperthyroidism. The third most important thing, this is the sick euthyroid syndrome, which is all of them low. Sick euthyroid syndrome. He will tell you patient hospitalized in ICU, having a big problem, big trauma, recovery from a severe illness, and you'll find TSH and all the parameter T3, T4 all are low. So this is sick euthyroid syndrome. Hello?
Hello?
Yes, I can. I think someone is asleep like me. Okay, next question.
A 40-year-old woman present with a parotid tumor. A biopsy revealed extensive perineural invasion, which of the following most likely pathology. So the perineural invasion is with adenoid cystic carcinoma.
Exactly, adenoid cystic carcinoma.
Give this. Most common benign is pleomorphic adenoma. Most common malignant is mucoepidermoid. Perineural invasion is the most common is adenoid cystic. Okay.
Yes.
Very important by the way in the exam. Most common benign pleomorphic adenoma, most common malignant mucoepidermoid, then adenoid cystic and perineural invasion. Next question.
A 50-year-old man presents with malaise, abdominal pain, weight loss, fever, and myalgia. Polyarthritis nodosa is associated with all of the following except erythema nodosum, livid reticularis, mononeuritis multiplex, nail fold infarct, palpable purpura. I will
Okay,
go
one of
with
the
it.
difficult. You'll go with
Erythema nodosum.
erythema nodosum. One of the difficult question has no explanation, or just you have to know the polyarthritis nodosa, the clinical picture, but it is not associated with erythema nodosa. Next question.
A 30-year-old woman undergoes subtotal thyroidectomy. 5 days later, the wound appears red and inflamed. Which of the following is most likely causative organism?
What is the most common?
The most common is
Most common organism for skin infection or surgical site infection.
strep.
Skin infection and surgical site infection. Most common organism.
Staph is for abscess. Yeah, I will go with the staph.
Staph or strep?
Staph is abscess, skin is strep.
No. Staph aureus is the most common organism for skin infection and surgical site infection. Staphylococcus aureus in part A and part B, most common pathogen for skin infection until he tell you erysipelas, until he tell you subfacial or fasciitis or something like this, or furuncles. You can go sometimes for streptococcus pyogenes, but Staph aureus is the most, as generally surgical site infection, post-operative or normal skin infection or abscess. Staph aureus is the most common organism. Clear?
Okay.
Make sure of it, but go for Google and surgical site infection organism. He will explain to you that Staph aureus is almost the most common organism for surgical site infection and skin infection as well. Next question.
A 50-year-old man complains of recent onset diplopia. On examination, he is unable to look inward and downward with his right eye. The most likely diagnosis is a lesion of the downward inward. Downward inward, I will go with the fourth cranial nerve.
Fourth cranial nerve. Excellent.
Okay. The eye movement and the direction of the gaze is a little bit confusing, okay? Because even if you went for some videos about the eye movement, the eye movement actually it is not strict to abduction, adduction, up and down. All the muscles are working at the same time in every gaze. In every gaze, all the muscles are working at one time. But what is the most powerful muscle and what is the direction of gaze is very important. This is an example of the direction of gaze and finding cranial nerve palsy. This is the most three important you will find in any cranial nerve injury concerning the eye movement. Third cranial nerve is very easy. You will never confuse them. Why? Ptosis. Okay. It is associated with ptosis. Whatever the gaze, he will tell you the patient can't look outward and upward and so on. Okay. So whatever, and there is dropping of the upper eyelid. So this will be third cranial nerve pulse. Fourth cranial nerve, the patient can't look inward and downward because the action of the
superior oblique muscle.
inferior oblique will make it look up. Superior oblique.
Fourth cranial nerves giving the superior oblique muscle.
Superior oblique muscle. Superior oblique muscle. Gives superior oblique and?
Only the superior oblique.
Only the superior oblique.
The sixth cranial nerve abducent is giving the lateral rectus. The rest of the eyes is given by the third cranial nerve.
By third cranial nerve. So superior oblique makes the eye to look
downwards and outwards.
Downwards and outwards. So this direction effect. You make me confused. Fourth cranial. No. I'm just started to be complete. Okay. Direction of gaze. I sent 3 video about the direction of gaze on the Telegram about 1 month ago, about how you can understand the direction of gaze and the muscle makes this. Here is the patient is looking. He is looking to. Here is the patient is looking outward to the left, and there is a problem with the superior oblique. The superior oblique should move the eye outside and down. In this direction of gaze, I think the one of the axes will be lost. So the eye should be normally here, but as the eye can't look downward, it will be directed upward by the by which muscle? Okay, I'm always confused in this gaze, but this is the right answer is the fourth cranial nerve. I'll send you the video on Telegram after we finish about the gaze and about the gaze. But looking inward is the fourth cranial nerve. The patient can't look. Make it simply, and I'm always trying to make it more difficult to understand all the eye movement and the gaze of eye. Make it simple. Third cranial nerve, he will mention that the patient has a dropping of the upper eyelid, and this is dropping of the upper eyelid, and this is pathognomonic for the third cranial nerve. Fourth cranial nerve, the patient can't look inward and downward. The 6 cranial nerves, the patient can't look outward. The patient can't look outward. Okay. I'll send you the video, but it is really confusing. You need to concentrate between the eye movement and the gaze and the axis of the eye.
The fourth cranial nerve's action is looking downward, inward. So when you lose it, the patient will look at the opposite. He will lose the action of downward, inward. So he will look upward, outward, because he lost the action of the
In
muscle.
the normal gaze, in this one, in the primary position. In the primary position, the eye will go outside. So normally, it will lose this action, so it will look upward. Okay.
Yes.
But here is just he wants you. He sometimes you confuse you by this position. When he tell you the eye look to one side of the gaze, one side of directions, the action of the eye will be. So this will continue like this, only up. It will not go for down, never will go for down. So here is upward and outward. If you look to the other side with the normal eye, the eye will still in the upward, but will be inward as well. Okay, I'll send you the video. Don't worry about this. Interesting video, but confusing video. Have it revised many times to make your imagination. But I think it is not confusing by any way. We never have a
I just want to add something simple. For the third cranial nerve, as you like, ptosis. For the fourth, we should be not confused between the action of the muscles and the lesion. So the fourth cannot looking downward and vertical diplopia. For the sixth, cannot abduct, so the eye is adduct.
Adduct, okay.
That's
horizontal diplopia.
Oh, horizontal diplopia, yes.
Exactly. This simply, but really, I'll send you the. And I have also a very nice photo about the direction of gaze and the direction of the muscle and the direction of gaze. Okay, it will be repeated in one of the recalls, by the way. I put this picture in one of the recalls. Okay. Yeah, we took longer time in this question. Next question. Okay, last 3 questions was Dr. Muhannad. Then we'll finish with who? Dr. Mu'tasim or Dr. Dafir?
As you like.
Okay, I'm with you.
Okay, can you continue, Dr. Muhannad, or you want to stop and then you want to continue?
I think he is sleeping now.
Okay, Dr. Mu'tasim. Dr. Mu'tasim, go.
Okay, a 57-year-old heart transplant recipient is keen to join the cardiac rehabilitation program. Which of the following factors is most likely to increase cardiac output in this patient during moderate exercise? Decreased negative intrasystolic pressure, decreased venous tone, decreased ventricular compliance, increased atrial filling, ITS, increased intrapericardial pressure. 57 heart transplant.
Forget about this.
Is most likely increase cardiac output in this patient during exercise.
Some of the difficult questions, by the way, answered by cardiologist, but I can't remember exactly what is ITS. Okay, it is increase atrial filling.
in transplanted heart patient to increase and rehabilitation program factors that most likely to increase how to increase the cardiac output in this patient by increasing the atrial flaring. Sorry?
Yes, it's D.
Yes, increase the atrial flaring. Increase the atrial flaring. Don't try to understand all cardiology.
I will say
Exactly.
that,
Some question try to this. If you want to know the cardiac physiology and the physiology of the transplanted heart, it means that you need about 6 months to study MRCS part A. Next question.
Okay, 69-year-old man with rectal cancer undergoes low anterior resection. The liver is disease-free. The pathology of his tumor was reported as a large tumor invading from the rectum into mesorectum. 2 nodes of 24 nodes close to the tumor were carcinoma on histology. The tumor was completely excised. What is the correct pathological staging of his tumor? Dux A or B or C or D or T2 in 1. Okay, according to the pathology, the tumor was reported large invading rectum to the mesorectum. So it bypassed the wall and there is lymph nodes. So lymph nodes means Dux C and no mets, the liver is free, so it's a Dux C.
Exactly. D is lymph node, is distant metastasis. And C and B has different type, B. But once we reach the mesorectum with lymph node, it's type C2. Type C2. Okay. Type B will not reach the meso, but it has B1 and B2 with or without lymph nodes. C is the same. C1 and C2 both reach the mesorectum, and local extensive or local invasion, but without distant metastasis, and has C1 without lymph nodes and C2 not penetrating. No. C1 and C2. This is a different one of classification here. I can send you. That means nodes makes C2 and B2 nodes involved or not involved. Okay.
Okay.
Now there is a different different diagram of this, by the way. It shows that D2 and B2 and C2 means nodes involved, and both of this is till the wall muscularis layer without invasion of the meso, and this with invasion of the meso. So this is whatever it will be Dukes. C as D is, we have distant metastasis. Next question.
Yes.
21. A 21-year-old man is admitted to emergency department with a stab injury to his right chest. Pulse rate is 110 beats per minute and the blood pressure is 85/40 millimeter mercury. Chest X-ray shows a large right pneumothorax and a very small light apical pneumothorax, which is the first substance secreted in the process leading to increased renal reabsorption of sodium in response to the above injury. Angiotensin 1, angiotensin 2, angiotensinogen, antidiuretic hormone, renin. So the patient is choked, and first thing is the release of renin, which will activate the renin angiotensin aldosterone system. So the first substance secreted in the process will be renin.
Exactly, very easy question, straightforward. Renin. Next question.
During the second phase of wound healing, the predominant cells in the wound site are fibroblasts. This cell is of mesenchymal origin and produces the matrix and the collagen needed to strengthen the scar. Cross-linkage of collagen requires hydroxyproline and hydroxylysine residue.
which requires a specific vitamin to be available in sufficient quantities. Deficiency of which vitamin results in collagen with unstable vitamin C, ascorbic acid.
Vitamin C, exactly.
A very long question.
Very long question. Yes, this is. Sometimes if you find very long question, have a fast look on the answers. And to know sometimes you find a very long question and you find at the end medial to lateral, medial to ulnar vein, medial to ulnar, medial to brachial artery, lateral to medial nerve, and so he will give you a big scenario about the trauma, and then he want to ask about the relation of two vascular structure in the anatomy. By the way, most candidates get from paper 1 and said there is many questions from paper 2. No, he starts the question like a normal scenario, like a patient had trauma and cut wound in the brachial plate and the brachial fossa, and then the patient has loss of sensation over the cut. What is the relation between the median nerve and the brachial artery? So you have to have fast reading. In most scenarios of paper 1 are just an introduction for a question. You want just tell us what's important for healing and the cross linkage of collagen and you want so vitamin C. Okay, no problem. Okay.
Next question.
Yeah, next question.
62-year-old woman presents with a fairly irregular mass in the upper outer quadrant of the right breast. This appears in malignant on mammography, and the fine needle aspiration cytology is reported as cancer, as CO, which is the first lymph node to which the tumor is most likely to metastasize. A, initial node. B, primary node. C, secondary node. D, sentinel node, Virchow node. I think the first lymph node to which tumor is sentinel node.
Sentinel node, and this is the node we took a biopsy, sometimes in locally advanced or sometimes in conservative breast surgery. We make conservation, we take lumpectomy or quadrantectomy plus sentinel lymph node biopsy, and then the decision of the operation according to the sentinel lymph node. If I have frozen section intraoperative, I can go for sometimes and if you have frozen section, you can start with the sentinel lymph node, by the way. And I did it maybe with some oncology consultants. We do during this operation, we took the sentinel lymph node, send this for frozen section intraoperative, and then when the results come, we depend to do quadrantectomy or total mastectomy. Okay, next question.
Which of the following statements is true with relation to cardiac muscle?
This is the worst question you'll find in the exam. That he's يعني question كده عايم كده tell me what is right about Dr. Mu'tasim. So he doesn't ask you مثلا what is right about مثلا Dr. Mu'tasim marital states. So you can go for he's married, not married, he's divorced. We do. But what you know about Dr. Mu'tasim? So what you know about what school, his knowledge, his job. Okay. This is really very bad questions in the exam. I hope I wasn't like before. Okay. What is right about the cardiac muscle?
Cardiac muscle contraction does not involve the release of calcium by the sarcoplasmic reticulum. It is wrong. Contraction is triggered by an influx of calcium through the sarcolemma. I think it is maybe true. Excitation is passed from one cardiac cell to another through desmosomes. Hypertrophy is brought about by division by existing cardiac cells. There is capacity for regeneration. I think contraction is triggered by influx of calcium.
Okay, I think so, يعني أحيانا when you face a question like this and you feel like you are started to be lost in this, if he repeated two sentences in different ways, so you have to expect this is the problem is white, and it is the answer will be within these two answers. Okay, so calcium is known to influx of calcium makes sacroiliacal contraction. So this is more close to be right. This involves release of calcium plasmic reticulum. Doesn't involve, it involves influx of calcium. I can remember from histology is responsible for the sarcolemmal contraction. Next question.
A 70-year-old retired farm worker presents with a scaly lesion on the back of his left wrist. A biopsy shows enlarged polymorphic squamous cells with mitosis that have breached the basement membrane. What is the name of this process? Dysplasia, hyperplasia, hypertrophy, metaplasia, neoplasia. The neoplasia because it breaches the basement membrane.
Okay, breaches the basement membrane. So we passed the dysplasia to neoplasia. What is the difference between of them? There is no breach in dysplasia. There is no breach of the basement membrane, but in dysplasia is breach of the basement membrane. Okay. Next question.
A 45-year-old man has established cirrhosis. At a follow-up appointment, a palpable spleen, 4 fingers breadth below the costal margin is noticed. For blood count, have shown a persistent thrombocytopenia. Bone marrow examination showed megakaryocyte hyperplasia. What is the most likely cause of the thrombocytopenia? Ineffective production in the bone marrow, platelet destruction in the bone marrow, platelet destruction in the liver, platelet destruction in the spleen, platelet storage in the spleen. So patient is cirrhotic and patient has splenomegaly and thrombocytopenia. I think it's platelet destruction in the spleen. Hypersplenism.
Hypersplenism and splenomegaly will cause platelet destruction by the spleen. Next question.
A surgeon is carrying out an elective splenectomy for congenital spherocytosis. Which structure will be divided in order to mobilize the spleen from the posterior abdominal wall? Gastrosplenic ligament, lesser momentum, lieno-renal ligament, phrenicocholic ligament, short gastric vessels. I think it's lieno-renal ligament.
Exactly, the lieno-renal ligament is on the posterior abdominal wall, and this is the last one to be divided. What is the first ligament to divide to access the spleen?
Short gastrosplenic.
Short gastric or gastrosplenic ligament is the first one. During splenectomy, because this question is very confusing and very common. During splenectomy, make the exploration. So you open the abdomen here, and then you pull the stomach out. So you stretch this ligament, then cut ligament. So the first ligament we will cut to expose the hilum of the spleen is the gastrosplenic ligament to expose the hilum of the spleen. After you cut this, you can pull the stomach out. So what you have here, you have the lieno-renal ligament with the splenic hilum. You put 2 clamps here. And cut between, and this is the lieno. To separate the spleen from the posterior abdominal wall is the lieno-renal ligament, and you can then tie and give a knot here and cut the spleen out and extract. Okay, so the first or the most anterior structure that you will divide to access the hilum of the spleen is the gastrosplenic ligament or short gastric vessels in the gastrosplenic ligament. The ligament you have to divide to mobilize the spleen from the posterior abdominal wall is the lieno-renal ligament.
Sorry, Dr. Rami, in question 123, we said neoplasia because it's breached the basement membrane?
Yes.
Okay, if it's not breached the basement membrane, it will be...
and there is pleomorphic cells, it will be dysplasia. Dysplasia means carcinoma in situ, by the way, or some sort of carcinoma in situ. Means there is pleomorphic cells and the cells show malignant features without breaching the basement membrane. Once breaches the basement membrane, it is neoplasia.
Okay, thank you.
Okay, next question.
50-year-old man is admitted with gastric pain and a rigid abdomen. He is diagnosed with a perforated duodenal ulcer. Ulceration due to excessive gastrin activity may be caused by increased levels of adrenaline, calcitonin, glucagon, secretin, somatostatin. Ulceration due to excessive gastrin activity, increased levels of maybe secretin.
No.
I don't know. Increased gastrin levels due to polypeptide epinephrine. Okay. It will be A.
One of the confusing questions, by the way. Okay, we all know that gastrin can increase the acidity and can cause peptic ulceration. But what here is asking, ulceration due to excessive gastrin activity can caused by, when gastric activity can be increased?
We know Zollinger-Ellison, which causes gastrinoma.
This causes gastrin. What causes gastrin increase? Sometimes.
Neural epinephrine.
That's why in stress condition, and some patients who are very nervous, or patient going to stress conditions, sometimes has some ulcers, because if it is long lasting complication, or patient always has a high epinephrine level, increase the high gastrin level, so the patient can go for a stress ulcer sometimes. So this is also one of the questions I searched it for a long time to find a proof why, especially because many can't, why adrenaline, by exclusion they choose adrenaline, but why adrenaline? This is the question. Increasing gastric secretions can have vagal stimulation, peptide, phenylalanine, and then in the blood calcium and epinephrine can increase gastrin secretion. Okay, Dr. Dhafar, can you, thank you, Dr. Mu'tasim. Can you finish last 9 questions, please?
Okay. A 66 years old woman with no tumor of the spine. He has started to retain urine and experience decreased anal and rectal tone. The tumor is passed directly on the cons medullaris. At which of one of the following vertebral level is the tumor most likely to be located? C.
C, exactly. L1, L2. Conus medullaris is at the end of the spinal cord, and the spinal cord end at the lower level of L1, and then start the conus medullaris at L1, L2, and then the rest of the spinal cord will go for the dura mater and the arachnoid and so on, will be below the level of L2.
In children at S2 or L3?
In children, will be at S2. At birth, at birth it will be at conus medullaris will be at L3 at birth.
L3. At birth will be L3. Keep this, forget about infant. At birth, it will be at L3. Okay, at the end of spinal cord, it will be at L3. In adult, the end of spinal cord will be at L1, so it will be at L1, L2. This is the most important. Conus medullaris, L1, L2 in adult. At birth, it will be at L3. Next question.
A 26-year-old man presented with a 2-month history of unilateral testicular swelling. An ultrasound scan show heterogeneous mass within the testis with surrounding fluid. His blood tests show elevated alpha-fetoprotein level, which of the following most likely diagnose? It is a teratoma.
Teratoma. In 20s, teratoma. 20s, teratoma. In 13s, and sometimes up to 40, seminoma. This is most common, and by the way, 20s, and forget about this. From 20 to 30, the teratoma. Above 30 to 40, it is seminoma. Above 70 is lymphoma. Next question.
A 15-year-old man presented with a history of fecal incontinence. Over the past few years, she had prolonged and difficult first stage of the labor 20 years previously. Physical examination revealed relatively lax anal sphincter, which nerve is likely to have been damaged in the labor. Anatomical nervous system, anatomical nerve to the rectum, genitofemoral nerve, lumbar sacral tract, obturator nerve, and pudendal nerve. It's pudendal.
What is the origin? Root origin?
C2, C3, S2, 3, 4.
Yes. S2, 3, 4. Very important for urinary and fecal incontinence. As we say, S2, 3, 4, keep the pee or the poo out of the floor. Okay, very important, this nerve. No exam without pudendal nerve. Patient doesn't get history of vaginal delivery. Patient went for episiotomy, and patient, you are going to do episiotomy and you want to inject local anesthesia, or what will you inject? Patient loss of control on fecal or urinary. All of these asking about pudendal nerve. Okay.
Okay.
Next question.
A 70-year-old man is admitted to the hospital with 12 for history of painful white leg. A femoral artery embolus is shown in the angiograph. He is insulin-controlled diabetes and taking ibuprofen for long-standing osteoarthritis. 24 hours after emergency embolectomy of the blood pressure is 19/60 millimeter mercury, and he passed very dark brown urine. A dipstick show myoglobin and trace of blood. Hemoglobin, his blood glucose is 15 millimole, normally 0.4 and 2.6 to 6. Urea 12 millimole, normal 3.2 to 7.5, and creatinine 180 millimole. What is the most likely cause of abnormal renal function? Drug-induced nephropathy, hypovolemia, methylhemoglobinemia, rhabdomyolysis, uncontrolled diabetes, rhabdomyolysis.
Okay, this patient presents with ischemia, femoral artery embolization, and then started to have rhabdomyolysis, and then the patient go for
myoglobinuria.
This is another another way I saw today two scenarios. A marathon 23 years
Exactly.
old marathon.
Yes, young patient in the marathon, and then he severe for a long time. Then the patient has severe loin pain and past urine. Then because of his aggressive muscular action or aggressive muscular effort can cause rhabdomyolysis as well, and can cause myoglobinuria.
Yes.
This is, I think, in last exam, yeah?
Yes.
Okay, next question.
86 years old woman with a history of the partial gastrectomy is the thigh is in the high dependency unit for the chest infection that's being treated with the antibiotic. She is complaining difficult of swelling. Endoscopic show multiple white plaque on the mucosal surface of the esophagus. Biopsy is most likely to show acid reflux esophagitis, birth esophagitis, candida esophagitis, eosinophilic esophagitis, herpes esophagitis. So it is candidial infection.
Okay. Exactly. This is very common in ICU patient receiving antibiotic for a long time, especially old age with low immunity. And so this patient is very susceptible for fungal infection. Next question.
A 65 years old woman has been given a total of 15 milligram morphine over a 30 minutes period for parallel follow femoral neck fracture. Mellowing observation are found. SpO2 on the 90% oxygen is 90%. Blood pressure 90 over 60. Respiratory rate 6 beats per minute. The immediate intervention should be high flow oxygen, intravenous fluid replacement, intravenous naloxone, monitoring ECG, and tracheal intubation. So it is intravenous naloxone. We need to reverse the action of the morphine.
This question has a lot of debates all over the social media. Everywhere. Hello, Dr. Rami.
Yes. Okay. I think we solved this problem before. You have two choices now. Give the patient high flow oxygen, okay, or
naloxone.
Naloxone if he have respiratory depression, or intubation. One of the indication of intubation is respiratory rate 6 beats or less.
Okay.
We was solving first, give naloxone, but when you go for indication for intubation, one of them is severe respiratory rate, low respiratory rate, and it is written sometimes less than 6 or less than 8 beats cycles per minute. You have to intubate the patient because naloxone will take time to reverse of the morphine overdose, and you have to save ABC first for the patient is airway and then breathing. If the breathing doesn't good, you have to intubate the patient. ABC first, intubate before giving the drug. ABC will be considered. So this patient, you will deal it as crisp patient. You go for airway, then breathing. Then when you go for breathing, you'll find respiratory rate 6. So this patient, you have to intubate. Okay, search about it and the indications for intubation and respiratory condition or respiratory distress. You'll find this, I think, less than 8 or less than 6 or 6 and less. Yeah.
House officer, doctor, told them we are doing all of these steps in the same time, giving naloxone and intubating and putting oxygen, everything.
This is right, yeah. And here is what is the immediate intervention. If you don't have naloxone now, I think immediate will be intubation is right. So if you're still waiting, I'm convinced with intubation.
Because
6 beats
naloxone
per minute, the patient.
not in everywhere, only the national.
Even if it is not available in your hand, but intubation, you can any place, any hospital basics has endotracheal tube.
Yes.
Next question.
The following drugs are used to treat patients with the peripheral vascular disease. They all reduce the rate of the myocardial infarction and stroke, except, okay, it's E.
Any pharma question, just know it like this. Okay.
Okay.
This is pharma question. So peripheral vascular disease, and this is easy. Peripheral vascular disease, any patient with peripheral vascular disease, what's called a medical treatment or life modulating treatment. This you give the patient ACE inhibitor, yes, antihypertensive, aspirin, and cholesterol lowering. Any patient with peripheral vascular disease, all this is giving what's called medical treatment or lifestyle modulating medication. Between the lifestyle modification, you give the patient antihypertensive, you give the patient angiotensin converting enzyme. Patient will take aspirin and cholesterol lowering agents, and if the patient is diabetic, we'll give him anti-diabetic medication. But oxypentaphyline is not described in patients with peripheral vascular disease. What is called, this is the best medical therapy for peripheral vascular disease.
Okay.
Oxypentaphyline
by exclusion.
Is a bronchodilator?
I think so. I didn't search for because I don't like pharma. I don't like pharma, I don't like pharma. Okay, next question.
A 4-year-old boy is brought to emergency department with the painful right elbow. His father tells that he was swinging his son by his arm when the pain came on. Sudden X-ray show that the radial head is displaced from the usual place. What ligament of the proximal radio-ulnar joint that hold the radial head in the place? Annular ligament, it's yes. Cricoid ligament, equatorial ligament, okay, radial ligament, ulnar ligament, no, sorry.
Annular ligament. One of the repeat questions also in exam in anatomy, and this is long scenarios, and he asks about the annular ligament. Last question.
Yeah. It's a 35-year-old man presented with the 3-week history of low back pain and the 3 days history of the pain and weakness in his left leg. Physical examination demonstration numbness over the posterior aspect of the left calf extending to the lateral aspect of the foot. Left ankle reflex is absent, and a magnetic resonance scan show compression of the left S1 nerve root. What is the most likely responsible structures? Annulus fibrosis, anterior longitudinal ligament, nucleus pulposus, or posterior longitudinal ligament, or vertebral end plate. So it is C.
Exactly. This question is like يعني اسم مبلط السيراميك اللي عمل لهم البيت. A long history of patient low back pain and examination and physical non-venous posterior. يعني you think he will ask you about the nerve root lesion or then at least he want to ask you about the structure of the
But this question is not famous and it didn't come before, huh?
والله يعني Fawzia Sheet is an example. Sure it came before يعني.
Yes, it
sure
came.
it came before.
Yes,
Yeah.
it came in many years.
Sure it came. Yeah. Okay, thank you. We finished first Fawzia Sheet. We finished it in 2 days. Sorry, يعني we finished it today. We start about takes about 6 hours. I hope
we'll not do the second sheet now.
We'll do it now. Yes, you can do it. No problem with me. You have the sheet and you can do it as you like.
We will do it. We will do it. We the four. We only the four. We will participate. I think the others will.
Okay. I think tomorrow I have all duty all the day. So tomorrow we can't meet. After tomorrow, I think one day will be postponed for the first recall after Fawzia Sheet. So after tomorrow we'll go again for Fawzia Sheet type 2, Fawzia Sheet second paper. I hope to finish it early. I want to run in questions, inshallah. We'll find many repeated questions. So meet again. Try to make it after tomorrow at 7, 8 o'clock, maybe 8 o'clock. So we can finish Fawzia Sheet as well, paper 2. Thank you, and hope you enjoyed this discussion, and very important discussion.
Great thanks for you, Dr. Rami, and for all four colleagues.
All colleagues who shared and participated today, thank you.
Have a nice dream.
Yes,
Stop recording, Dr. Rami.
Yes, as the recording, when it is busy, I can send it to the group, no problem. Okay.
Stop recording now.
Sorry?
Stop
I'll stop recording.